Ready, Madam Clerk?
Yes.
Yeah, okay. Good morning, everyone, and welcome to the House Committee on Health, Human Services, and Elderly Affairs. As noticed, we have several bills scheduled for public hearings today, but before we get into those, please join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you, everyone. The first bill to be heard this morning is HB 1584FN. The prime sponsor, Representative Kelly Potenza, is already in place. She knows the drill well. And Representative Potenza, proceed, please.
Thank you so much. Just for the record, Representative Kelly Potenza, Stratford District 19. I'm here to talk about 1584, which is a bill that's it's a simple bill, and that basically is to, as the Act here says, directing the Department of Health and Human Services to provide notice of medical and religious exemptions from immunization requirements and relative to the form of such exemptions. So I thank you the opportunity to introduce this bill. This legislation is not about changing New Hampshire's immunization requirements, eliminating vaccines, or discouraging vaccination. It is about truthful disclosure, statutory clarity, and respect for rights that already exist in New Hampshire law. New Hampshire law has long recognized medical and religious exemptions from immunization requirements. These exemptions are not new. What has changed is how clearly or how consistently those rights are communicated to parents and the public. This bill addresses that gap. The bill requires the Department of Health and Human Services, when promoting vaccination, to clearly disclose that medical and religious exemptions are available under New Hampshire law. That notice must be prominent and not buried in fine print or in links. The bill also clarifies that parents are not required to use a state-created form to claim a religious exemption. Any signed written statement attesting to a religious objection is sufficient, as already allowed under our law. This bill creates modest accountability to ensure compliance and requires an annual public report to the legislature so oversight can occur transparently. This bill does not create new exemptions, remove immunization requirements, or prevent DHHS from recommending vaccines. It is simply ensures that the existing law is communicated honestly and consistently. Transparency builds trust. When parents receive complete information, they are more likely to engage responsibly with schools and healthcare providers rather than feeling pressured or misled. This legislation protects religious liberty, respects parental rights, and reinforces legislative intent without interfering with public health operations. I respectfully ask for the committee to support this bill. I'm happy to answer any questions. I would like to just give an example of basically it was like a placard in the pediatrician's office. It pretty much stays up all year long, along with a lot of other promoting vaccination placards. So I kind of want to keep this, so I'm going to pass it around to the committee. But it's basically a back to school checklist. And it says, New Hampshire state law requires that all middle school students be vaccinated against 9 preventable communicable diseases. Before your child heads back to school, please follow these important steps. So it tells them that they got to go get their book bags, their pencils, their notebooks, and their vaccinations, and not anywhere in this notice at all does it talk about religious or medical exemptions. Based upon this notice, it says you can't go back to school unless you have that. So this is just one example, and there's many. The site has changed. DHHS's site has changed. They had everything from coloring books to about promoting vaccinations and all of these different types of things. And we don't do the same. We don't do the same. We promote one side of that, and we don't give the full story. And I think it's very important that we have all sides of the discussion present. So I just think that this is a good example.
All set. Thank you. One announcement I meant to make before we got into the hearing this morning. We've had a little bit of a change on the committee here. Representative DeLamus is our new clerk, and thanks go to Representative Drew for his distinguished service over the course of the last year.
Nice.
I guess I burned him out. I guess the committee burned him out. But thank you both for your service. Question for Representative Potenza. Yes, Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question. Looking, I haven't seen it yet, but does it say there when it says vaccines on the blackboard for things to be concerned about? You said that it gave the message that you cannot go to school until you've had vaccine. Does it say the same thing for the other items listed? You can't come to school until you have a backpack? Well, if I'm inferring that it's on the blackboard that I can't attend school until I'm vaccinated, that means I can't attend school until I have a backpack. Is that correct?
No, if you read it, it says at the top what is required to attend school, and then that's just a graphic. It doesn't in any way tell parents that are in the pediatrician's office. And just so you know, this is the largest medical provider in the state of New Hampshire. So they're seeing thousands upon thousands of families. They see that all day long, every single visit, and it doesn't have that, and it needs to stay that. We have to have both sides of that discussion.
This will explain it.
Representative Palazzo.
Thank you, Mr. Chair, and thank you for presenting this bill to us. I like the intention of this bill, but in the fiscal note, our Department of Health and Human Services assumes that the only way this bill can work as written is to hire a part-time specialist who will be working on those notices and compliance report, and we would need to spend over $40,000 every year on such part-time specialist. So was it your intention with this bill to have some additional part-time specialist, or is there any way we can adjust this bill to make sure that maybe it's revenue neutral?
Yes, 100%. And I'm so glad you asked that question. I was deciding whether I was going to put that in my testimony or not. I do believe that fiscal note is exaggerated. I am basically looking for when things are going out, okay, so just so you know, the notice that I'm sending you is something that doesn't get laminated by the department and then distributed. These are all downloadable documents, like PDFs, that can literally have prominent, on there that religious and medical exemptions are available in New Hampshire. That's all I'm asking for when it comes to that. The other piece is mostly a lot of electronic pieces of information, which right on the website. So the compliance piece, if we need to, you guys, this is your bill now, right? And if you need to amend it to make sure that it's revenue neutral, I'm 100% for that, because I don't want it to cost anything. We are in a budget crisis, as we talk about all the time, and this is not to make anybody's job harder. It's just literally pretty much providing informed information to people.
Thank you.
Representative Kesselring.
Thank you, Mr. Chairman. I have a question on line first. It looks like the first page, line 27. And it actually goes on the second page, 1 through 3, specifically to the criminal penalty, let's call it, and the cost. Was that pulled from another statute? Was that pulled from some other part of law, or is that actually just something that was created?
Yeah, something that was I worked on this, of course, with OLS, and we have a lot of laws in New Hampshire that don't have any sort of enforcement mechanism. I think the department will comply and probably won't have any issue at all. I have full confidence in the department, but I just think that when we are passing legislation, I really believe that we have to start putting accountability on all of our bills. To me, they're not worth much of anything if they're just on paper. So, because there's no real enforcement mechanism. So I think that having something like that on there keeps everybody accountable.
Follow up?
Did you check to see if there was anything in current law, or did you ask to see if that was something you could just add?
I asked, this was, OLS said this was fine, so.
Anyone else? Yes, Representative McLean.
On the penalty portion, though, I mean, do you think it might be a bit broad because it says anyone who authorizes or distributes? So does that mean the IT guy who has it and uploads it, he's culpable, or someone who drives around and distributes? So are your thoughts, we can maybe scale that back a little bit, or?
Yes, of course. You can have guardrails on there to be specific. Like I said, most of these things are electronic. They are downloaded from a portal, and then they're laminated by, Dartmouth Hitchcock, and then they're posted up. Like, a lot of these things are that. If it is, if the department, for example, spends, several $1,000s on a campaign, a billboard, or something like that, not like saying that that's going to happen, but if they did and they didn't have this on there, well, that would obviously, they would be responsible for that. So I think that definitely you can fine tune that as much as you need to make it specific.
Representative Weber.
Thank you, Mr. Speaker. Thank you for taking my question. I'm just wondering how we know if the thing that's posted in the doctor's office came from the Department of Health and Human Services, or was something that was created in the doctor's office by the doctor's staff who have no idea about this requirement, and how we are going to make sure that we are not prosecuting people at DHHS for something that DHHS did not create.
Well, it's crystal clear because if you look at the handout, it literally says it's from the department. So it would only apply to department. So thank you.
Representative Woods.
Thank you, Mr. Chair, and thank you again. Again, speaking to the issue of being perhaps overly broad, it begins by saying any communication. Let's say that Dr. Chan is giving a talk to Rotary about vaccines. That's a communication. Now, does he have to carry in some way a disclaimer along with his presentation?
No. I've seen Dr. Chan speak multiple times. I'm not sure if he's here today. Oh, he's behind me. Hey, Dr. Chan. So, so I have never seen him in a public forum tell everyone that they have to go out and get any sort of vaccination. He gives information. He provides all of that kind of stuff. I don't really think that it would apply. He's a very, very intelligent man. I've never really seen anyone do that. So, but if we had a public official that went on WMUR and told everyone that by law in New Hampshire, you are required, you cannot go to school unless you have X, Y, and Z. That's it. And they don't mention medical or religious exemptions. Yeah, that would be applicable here.
Any other questions? So yes, Representative Lucas.
Thank you, Mr. Chair, and thanks for taking my question. Since the governor vetoed House Bill 358 this past July 15th, which is very similar to HB 1584, are you aware of any changes in the nature of infectious diseases in New Hampshire that have occurred since then that would make this bill now relevant when it wasn't just 6 months ago and was vetoed by the governor?
Well, this bill in its entirety wasn't the bill that the governor vetoed was one little piece of this, and I think there was some miscommunication there from that office. It was, if you look on the website, and I could show you right now because I've read it multiple times, the department uses the word shall, and that's actually not true. By our law, that you are not required to use the DHHS form. That was what needed to change. You can use their form that they created. That's fine. That's, if people want to use that form. But I can just tell you, myself and 100 other families used the form that I created that basically in regards with religious exemptions for my children. You could scratch it on a piece of paper, put your name and your child. It doesn't have to be, someone does not have to go to the DHHS website and use that form for their religious exemption. So the rest of my bill has nothing to do with what the governor vetoed. All I want is that shall needs to change because that's actually not correct.
Thank you.
Anyone else? Okay, thank you, Representative Potenza. For those of you who have been in front of our committee before, custom is to allow the prime sponsor a little extra time to explain the background of the bill and accord other testimony 3 minutes each, and then obviously allow for questions after. Next to sign up and ask to speak is Megan Heddy and Dr. Benjamin Chan from the department. You've asked for 5 minutes. I assume that's for the both of you, or? Okay, thank you.
Testing. There we go.
It's working.
It's working. Just reposition here. Well, good morning, Mr. Chair and members of the committee. Thank you for the opportunity to come before you this morning and speak on House Bill 1584. For the record, my name is Ben Chan. I'm the state epidemiologist at the New Hampshire Department of Health and Human Services. I'm also an infectious disease physician, and I'm joined today by Megan Heddy, who's the chief of our Bureau of Infectious Diseases and Public Health and also a registered nurse. I'm going to take the first half of our allotted time to talk specifically about the communication aspect of House Bill 1584. Then I'm going to turn it over to Megan to talk a little more about the form and some of the financial implications. But the department is opposed to 1584 for a number of reasons. I think first among them is our concern about the wording in here around the required statement for any immunization communication where we would be required to display the statement that medical and religious exemptions are available under New Hampshire law. As has previously been alluded to, that we believe the statement is overly broad and does not differentiate between the type of communication, the target audience, or the subject matter that we're communicating on. And so the required statement would not, we believe, apply to the majority of communications that we conduct around immunizations. And just as an example of this, as I think most people are aware, every year we put out communications to healthcare providers, to the public around respiratory virus immunizations, RSV, COVID, flu, which are not required immunizations for children attending childcare or schools. But the way we read this bill, we would still be required to make statements that medical and religious exemptions are available, even though that statement doesn't apply to that communication. We do routinely have information and messaging that we put out about medical and religious exemptions. Our website and Department of Education website, I believe, child care licensing web pages all currently have information about medical and religious exemptions which are available. And if people want to claim them, they have the ability to go on and look at that information and utilize the forms that are available. But we're concerned that the broad nature of this will negatively impact all forms of communication we put out about immunizations, even if it does not pertain to child care and school requirements. The final thing I'll mention before I turn things over to Megan here is that the financial penalties that are proposed appear to be against individual employees, not against the department. And so, for example, if I were to put out a communication that's not relevant to the statement on exemptions, I personally would potentially be looking at a financial penalty, and other state employees individually would be looking at penalties. And so, for that reason, also, we are opposed to this bill. But let me turn things over to Megan to talk about the form.
Thank you. So about the medical and religious exemption form, currently RSA 141C20C allows for medical and religious exemptions to school and child care immunization requirements, which does balance public health protection with a child's medical and religious beliefs. If House Bill 1584 were to be enacted, parents and guardians that identify a religious exemption to immunization requirements would only need to be able to provide a signed statement, as we spoke about earlier, which could be informal as an email or just a handwritten note. The current religious exemption form was adopted through administrative rulemaking process and is helpful for schools and childcares in having a clear process for religious exemptions that accurately inform parents about their options. Notably, 1584's reference to any written signed agreement creates a contradictory requirement in statute, since RSA 14120C2 still contains wording that parents and guardians shall sign a form for religious belief exemption. Additionally, as we brought up earlier, this legislation was a provision was similarly brought up and was vetoed in the 2025 legislative session, which was House Bill 358. And that was sustained by the House because a process for religious exemptions already exists, and changing that process was considered unnecessary. The department also opposes 1584 because of the proposed punitive financial penalties against department employees who communicate about evidence-based immunization information throughout the course of their daily job duties. These penalties are a deterrent to department employees in carrying out their work and protecting the health of individuals and communities. This bill also proposes the development of an annual compliance report, which will require department staff a new part-time medical health services specialist. And we estimate that will take about 9 months for us to comply between hiring this individual, reviewing our current documents, and making the adjustments that are in this proposed legislation. Thank you for the opportunity to address this bill, and I'm happy to answer questions or provide any other additional information.
Thank you. Representative Kesselring.
Thank you, Mr. Chairman. I do have two questions.
Sure.
The first question is, can you walk me through the process right now if somebody asks for an exemption? Like, what is it that the department does for that, let's say, that family that asks for that?
So the individual who will need to speak to their healthcare provider or use that form where schools and childcare facilities, they'll be able to download that form, complete it, and sign it and submit it to the individuals that are looking for that. So whether that's schools, whether that's childcares that are collecting that information so that they have a record on hand.
And if I can just add, we don't collect that information, so the forms don't come back to us, right? They go to the school, for example, or the child care agency, and they keep a record of it. So part of the purpose of having a standardized form is for consistent record keeping within the schools, within the child care agencies, and based on the bill last year, what we heard from partner agencies or in schools, for example, was that they liked the form because it provided that standardization. We don't get that form, we don't get that information unless, for example, there's an outbreak at the school and we have to, go in and assess who's vulnerable in the school.
Representative Weber. I'm sorry, did you have another one?
Just a quick follow-up on that. So you talked about the funding and the cost. Do you see any other way that this could be enacted, let's say, without having to have another person where it's just a simple notification?
We would have to continually assess. The work that it takes to compile this annual compliance report will take an individual to review every single communication. And as we spoke to earlier, these communications can be broad from Dr. Chan providing information to the public, to us communicating with healthcare providers, to communicating with schools. And so there's multiple layers and multiple communications that we do daily that would have to be evaluated and assessed.
And what I heard from Representative Potenza earlier was that the intent of this bill was not to be overly broad. So one suggestion for the committee to consider is simply narrowing it down to the target audience and the target messaging. that's intended. But right now, as it's written, we interpret this as being very, very broad and affecting all of our communications on immunizations, whether or not it pertains to childcare immunizations and whether or not it pertains to requirements or not.
Representative Weber.
Thank you, Mr. Chairman. Thank you for taking my question. Am I right in thinking, because I don't have kids, so I don't have kids in schools, that the point of the form, which is, if I am correct, kept in the school and not in any way transmitted to the department, is so that the school officials will know in case there is an outbreak of some kind of communicable disease, the appropriate way to communicate with parents about the risk to not only the individual child, but other parents' children who all attend the school and also have rights to attend safely.
That's correct.
Thank you.
Excuse me. Again, just to, I think, repeat something we alluded to earlier, these forms are kept at the school for their record keeping, and so would maybe suggest that talking with some of the school nurses that oversee this process at the local facility level or childcare providers may also be helpful to understand the importance of standardized record keeping and how they use it. But from the department perspective, again, we don't have routine access to these forms. They don't come to us. They're important for the schools to have on record in a standardized way so that if there is an outbreak, we can go in and very easily assess, through their record keeping, who might be vulnerable so that we can, put a stop to an outbreak, for example.
Thank you.
Representative McLean.
Thank you, Mr. Chairman. Thank you for taking my question. So I take your point about the broadness of the bill, and I also have some concerns about the financial penalties being directed against employees, against the department. But I'm sympathetic to the intent of the bill in terms of promoting transparency. I think that's important. I'll just give you a very brief example of what happened to me in 2021 at the end of the state of emergency for COVID.
Excuse me, Mr. Chairman, is this a question?
Yeah, it is a question.
It is a question.
Okay.
So I wanted to opt out of the vaccine registry. I went to 24 different clinics, 24 clinics. None of them knew that I had the right to opt out of the vaccine registry. I even brought in the form. I pointed them to the HHS website. So this is why I really feel that transparency is very important. So while this may not be the mechanism, or maybe it is, could you kind of walk us through how is that communication delivered both to the parents and to the schools, and what is the process? Because I just kind of want to understand that better relative to what this bill is trying to achieve.
So maybe I'll start and I'll see if Megan wants to add anything afterwards. The requirements for school and child care immunizations are in statute, RSA 141C. The operations of how that gets communicated, for example, from a school to a parent, generally happens between the school and the families, right? I mean, I know as a parent myself that every year I get an email from the school nurse oftentimes, or the superintendent, highlighting, what's required for new students attending, and that I believe, if I remember correctly, the school is communicating that religious or medical exemptions are available and how to claim those. So that's not something that the department routinely communicates directly to parents on a routine basis. We have, obviously, resources on our website to support implementation of the law, but the direct communication to parents of school-age children or children in childcare usually comes from the school or the childcare agency. And so maybe that's another important point, is that the majority of communications directed to parents, in my experience, at least as a parent, comes not from the department but from the school or the childcare.
quick follow-up, Mr. Chair. So, and that kind of falls back into my experience with the registry. Obviously, the pharmacists, the rules were there, but the pharmacists didn't know about it, and I couldn't get into the opt-out of the registry. So what mechanisms do you have in place, I guess, to understand or evaluate what is the nature of these communications? And is that possibly a better way to go? I'm just trying to get to what is the best route to transparency, because I do think maybe it needs to be served a little bit better.
So, Representative, thanks for the questions. I will collect my thoughts here for a second and make a couple points. One is that during the registry use during the pandemic was one of those situations of building the plane while we fly it. So I recognize that there were challenges that you're highlighting with that in that specific example. The school immunization requirements have been in place for many years, and so would suggest that that's a different example or different situation than what people may have experienced during the pandemic. I think partly what you're asking also highlights the importance of having a standardized way of collecting the information and the data, a standardized way of having a form to be able to consistently communicate to and receive information back from parents, right? That form is a method of communication for collecting medical and religious exemptions. But in terms of your underlying question about, like, do we assess the quality of communications, for example, coming out from schools or childcare agencies, my understanding is that that's not something we routinely do or have the capacity or right? We're not the ones communicating. It's our ability to evaluate communications coming from the hundreds of different agencies across the state is limited. I don't know if Megan wants to add anything.
I'll just add that we do have partnerships with school nurses, the School Nurse Association, and we do have regular communications with them as well. So there is a mechanism to help provide some of that clarity through them. We also are freely available to talk to any school nurses that do have questions. So the department is available for any questions, confusion points, anything that we can help the schools with as well. So that's always available to them.
Thank you. That's very helpful.
Yes, Representative Lamontagne.
Thank you, Mr. Chair, and thank you for taking my question. Do you think if this bill passes, it will decrease immunization rates? And if so, what are the consequences to that?
Thank you for that question, Representative. So immunization rates have been trending downward over the last several years. So there's already a downward trend in immunization rates in the state of New Hampshire. Small, but it's there, and we can see it in the graphs. I think it's difficult for us to predict what will happen with a change to not requiring a specific form. I think it's certainly possible that there will be a further decline in immunization rates, but pinpointing that to a change in the form is going to be very difficult. So I think we generally expect that there will continue to be declines in immunization rates, but whether or not that's going to accelerate due to changing the requirement of a form, I think is difficult to say.
Representative Palazzo.
Thank you, Mr. Chair, and thank you for being here. I have a question about keeping a list of all promotional campaigns. So on page 2, line 10, you said it will be somewhat burdensome to review each campaign for compliance, so it might require a part-time specialist. But in terms of your current procedures, could you explain if you keep track of promotional campaigns and how many different offices and specialists are currently involved in promoting vaccination?
Thank you for the question. Effectively, almost every single one of our staff members involved in the immunization program participates in some form of communication, whether that's to healthcare providers, whether that's to the public who's asking us questions, or partnerships, anybody we have. And so effectively, every individual that we work with will have to have a single point person to be able to compile all the different communications, all the different levels throughout that entire year. And so having that additional staff member allows that focal point and that funnel point to be able to compile that, have a clear document for folks to review, and to present that very clearly and effectively.
Follow up.
When you say every single staff member, are you talking about Bureau of Infectious Disease or about DHHS in general?
We have our immunization program that obviously is very focused on immunization work, but in the course of disease investigation or any other kind of outbreak investigation, it would be the Bureau of Infectious Disease Control as well.
Other questions? Yes, Representative Cofal.
Thank you, Mr. Chairman. Thank you for taking my question. So, do you not already have a review process for communications that are going out from the Bureau of Immunization?
Thank you for that question. Yes, we do. We have a thorough vetting process internally within the program, within the Bureau, and within the division.
Follow up.
Thank you. So, how would this then be burdensome if you already have a review process for outbound communications to make sure that you are compliant and communicating clearly and so forth?
It would be to compile the report that is being requested in this bill. It would be combining all the information that's collected, making sure it's presented in a well-formed fashion, and that's why we would need that additional specialist.
Representative Delamus.
Thank you, Mr. Chairman, and thanks for being here. I too believe that the information is important to disseminate to the public, to schools. Obviously, there's somewhere where there's a lack of information being handed out. So if we did narrow this bill down, do you think that it would serve to inform the schools, the teachers, or not necessarily the teachers, but the nurses of the exemption that they may be unaware of at this point?
Thanks, Representative, for that question. We already do inform the schools and the nurses that they're well aware, as I think Megan alluded to. You know, we have routine communication with the school nurses, and I'm fairly sure that school nurses are informed of the requirements.
Oh, I'm sorry. Okay. Sorry, Representative Lucas. I didn't see you.
The last response answered my question.
Okay.
Thank you.
Okay, thank you. Representative Mazur.
Thank you for taking my question. So just as a follow-up to Representative Cofalt and his question, and you said that you already track compliance and that someone would just be needed to file a report. So $43,000 in the fiscal note, that would be the cost of creating a report?
Let me clarify. So we have a review process for communications that go out. We don't have a process, obviously, in place at this moment for compiling exactly what information is going out consistently and then compiling that. And so the cost of a part-time medical specialist that would need it to be able to fulfill the requirements of this bill would be that $43,000.
Anyone else? Follow up?
It's a different type of question, but can you just explain why is a form needed? Why can't a parent just send in, let's say, an email or just a statement and have that be what's on file? Why invade the privacy of a child with that form when you take the word of the parent through their own written communication?
Thanks for that question. I think it's an important clarification and point to make, Representative. I'm going to maybe start and let Megan chime in, but just to start off by saying that the department is not invading the privacy of any parent or child. Again, we don't get these forms these forms are collected by the school, which already has a record of all the children. The forms also collect. I mean, essentially, it's assigned. It's essentially a signed form stating that a child with appropriate identifiers has a religious exemption, right? It asks for name and date of birth. I think there's address on there as well, and then a signature, right? That's a relatively low barrier. And so if you're asking about having a signed statement for a religious exemption, that the form does that with collecting a minimal amount of information that's housed at the school, not at the department. And it's simply a way of having a standardized way of record keeping so that the information, the data can be more useful to the schools, reported more easily by the schools, less time and effort on the part of the school so that they're not developing their own system, and can be used in the event of an outbreak by the department, but that's a minority of situations. I don't know if you want to add anything to that.
I will just echo, I do have a copy of the religious exemption form if anybody would like to see it as well. I'll pass that around in a moment. But I'll just echo what Dr. Chan said. It is a way for schools and childcare facilities to standardize processes, have clear record keeping, and to be able to replicate year after year what they're trying to compile for students.
Representative Kesselring.
Thank you, Mr. Chairman. Question for you. If there was an email sent to, I'm just running a hypothetical, if a parent sent an email to the school and let's say the healthcare person in the school were to fill out the form for the parent, they wouldn't have to sign it. Would there be any other issues that you would find with that? Let's say they have it on file, but the parent doesn't have to sign it.
I think you'd have to talk with the schools about how that would impact them and their processes. I mean, obviously it's extra work on the part of the schools and the school nurses, which are busy doing other things as well. But I think that the request there of the schools would be to take more time with their, implementing a standard record keeping process. But I think that's a question for the schools.
Representative Copewell.
Thank you. So, seems to me that a standard record keeping system, given the simplicity of this information, might be a file folder or an Excel file. This didn't exist prior to the statute being changed. So the statute was changed to eliminate the requirement for a notary. So was this was some kind of inadequate record keeping identified by the department prior to that change as a flaw in the system or a fundamental need that that schools had a problem keeping track of who had a religious exemption?
I'm looking at Megan to see if she knows how far back the use of this form went. There was a law change several years ago where there previously had been the requirement for a notary, and then the notary was removed, but there was still a form before that. I believe. I could be wrong. No? Okay. Well, we'll have to look into that, and I apologize. I'm not intending to provide wrong information here. But yeah, thanks for that question.
Okay. Representative McGrath.
Thank you for taking my question. The form that you have, is there a warning to parents on there, and can you read that?
The form is going around. I can pass another one here as well. There is a note that parents are responsible for providing a copy of this form to each child care agency or school intended. There's information about which specific vaccines this exemption applies for, and that is a checkbox piece.
Okay. Anyone else? Seeing no one else? Thank you very much.
Thank you for your time.
Also signed up to speak is Representative David Nagel. And as a former member of the committee, he knows the 3-minute rule. He's even indicated he only needs 3 minutes. So,
Thanks, Mr. Chairman. I almost called you Mr. Speaker, sorry. I'm gonna hopefully be brief here. Mike, just to introduce myself, I've been a physician practicing in New Hampshire for the last 37 years. I specialize in physical medicine and rehabilitation. We deal with people with complex disabilities. There were two historic events that created my specialty as it exists now. One was the end of World War II and the disabled soldiers coming back. The other were the polio epidemics of the 1950s. I started the only post-polio clinic that's ever existed in this state. We dealt with the late effects of polio, and it was really kind of a sad process. I'm also a business owner. I did own 4 medical businesses until I gave them up for this job. I also started 2 nonprofits. I've been involved in labor management relationships for my entire career, and I still am to this date. I said that I don't support the bill. My only concern that I'm going to express today is on Section 3. The other 3 sections of the bill I have no opinion on. And this is more of a general concern than just this bill. I wanted to share a story with you. I don't know how many of you know who Glenn Hall was. He died last week. He was 94 years old. Glenn Hall was the goalie in the iconic picture with Bobby Orr in the 1970 Stanley Cup Final. He was also referred to as Mr. Goalie. He played 502 consecutive games, never once wearing a mask in the 1950s, 1960s, and early 70s. He was asked at the end of his career what it was like to play goalie in the NHL. His response was, imagine that you're at work surrounded by 15,000 people. You make a mistake, and a bright red light goes off, and 15,000 people start booing you, and you have nowhere to go. And somebody said, yeah, that's a pretty big deal. We've been working with employees and how labor and management should work together for a long time. We, on purpose, do not design businesses to function in that manner. One of the observations that we've made is that the 2 things that are most important for employee maximizing their productivity is how the employer likes the job, or likes the employee, and how much the employee likes the job. And anything that interferes with those 2 things is really problematic. That's where I'm really concerned about this penalty phase. Virtually every business in the United States has some level of accountability for employees. Employees make mistakes all the time. That's a given. You know they're going to do it. The question is, how do you deal with that when they do it? And that's what I'm really concerned. This penalty phase, I have a big issue with the dollar amounts, primarily because, we know everybody in health and human services makes millions of dollars. They're just floating with bucks. The reality is there's a huge difference from one person to the other. And I really think that we need to seriously look at how we look at accountability, how we penalize people. The dollar amounts are way too much, and I think there's dramatically better ways to do that. And I can guarantee you in my business, we do it in a very different way.
Thank you. Any questions for Representative Nagel?
Sorry, I don't get it.
Yes, Representative Weber.
Thank you, Mr. Chairman, and thank you for taking my question. I'd like to know if you could give us a very short statement of how you do it better.
How I do it better? So in my business, we have a handbook that every employee gets. It's about that thick, but it deals with very specifically outlining, issues and, in the workplace, concerns that we may have, and then a list of how you would go about dealing with the problems when they happen. Like, you're not going to fine somebody $1,000 for a first offense. I mean, that's just crazy. I mean, but at the same point, it's like, well, you need to be called to accountability for what happened, and the purpose of it is not, to punish you, but to educate you. And how can you do this better in the future and not make these same mistakes going forward? I mean, when businesses don't do that, they fail. And to be honest, in a business that would do it the way that's being suggested here, I'm sorry, I'm not going to come work for you. And that becomes a labor problem for you. And that word does get out. This is how you're doing it. The reason why the state's been so successful for so long in terms of hiring people is, number one, we have wonderful people in health and human services. I've really enjoyed working with my time here. But also we give great benefits, at least we have in the past. That was the reason why people come here and not go to other jobs. When you start doing things like this, you change that thing, and you may have long-term ramifications on who you can hire.
Yes, Representative Drew.
Thank you, Mr. Chair. I have two related questions. In your business, when an employee makes a mistake, are they typically breaking the law?
No. Yes and no. There have been instances where the law has been broken. Yes.
Follow up, Mr. Chair.
Follow up.
So if you had an employee who made a mistake, for example, that they violated HIPAA and exposed patient information, what would happen to them?
It depends on the nature of the offense. It's brought into the management. They sit down, look at the severity of it. There was only one, and I'm sorry, I'm blanking on this, but there was only one particular thing that were called for mandatory firing. Everything else was an education process.
One more.
But if an employee did violate HIPAA, would they not be subject to prosecution by the government?
I'm not totally sure about that. I don't think so.
Thanks.
Other questions? Seeing, Representative McLean.
Thank you, Mr. Chair. Thank you for taking my question. So I take your point about the penalty section of this. I think this I don't think is how things really work in the real world, although maybe we could revisit another approach. But on the notification side of things, the concern of the department, is that it's too broad and maybe it's not tailored to every communication. But if we were to revisit the notification part to narrow the scope down to those communications that are appropriate, do you think that this bill is taking the right approach to maybe enhance communication, or do you think that that's not where the gap lies?
It's an interesting concept. I have to tell you, I've been on the Opioid Abatement Commission for 3 years and had no idea how to access information on our website. And I finally found out it was fairly simple. It's not an easy task to get this kind of information out so people have ready access to it. I think it's important. I do appreciate the point of the bill. I think that's what you're getting at. I appreciate the point. My concern is really how we choose to penalize when people violate. And I think that needs to be refined dramatically. The concept of the bill is all right. My other concern is this. I think the sponsor did a nice job of saying what the department does well. But I do want to emphasize that there is a cost to having lower vaccination rates. We will see polio again, which is good news for me because I'll have work to do. But that's not a good way for me to get work. I do think there's an equal opportunity thing that both sides need to be presented to patients. Like, this is what happens if you're not vaccinated. This is what happens if you do. That kind of thing. So as far as what you're saying is, yeah, no, I think the bill's all right. I just think that the penalty phase needs to be revisited and adapted.
Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. I'm confused why you think $1,000 is high comparatively, because we have situation when trust in medical professionals are going down. And for example, we have situation when certain forces may use our government to promote certain drug without disclosing known side effects or existing exemptions. So if we have a case of violation like this, why do you think $1,000 is too much?
This is the way I look at it. I think the bill is written as up to $1,000. It doesn't really specify anything from, like, you made a mistake to, $1,000. How you're going to deal with that from a first offense to like a millionth offense. If this is like, consistent behavior, that's one thing. If it's a one-time thing, that's another thing. Well, how do you differentiate between the two? Because they're not the same thing. And I don't even know how you go about doing that. I know how we do that with our manual in my business, but I don't know how the state would do that, how they do it now. I'm sure they already have a way. I can't believe that they don't have a way about doing that right now without a fine. Money is a relative concept. Dr. Chan is a multi-billionaire, we know, so for him, $1,000 is nothing. For somebody that's a low-level employee that's making not a huge amount of money, $1,000 is a lot of money. I just think that needs to be revisited, dramatically refined. Typically these things are done in rules, they're not done in statute. I don't know how they would do it, but I think it needs to be dramatically more refined than that.
Okay. I see no one else? Well, thank you, Representative Nagel. Also signed up to speak is Colleen Ferrier from Concord, from the New Hampshire Nurses Association. You've asked for 2 minutes. There you go.
Okay. I'm writing to you on behalf of over 1,200 nurses who are members of the New Hampshire Nurses Association, and as a nurse primarily in New Hampshire for 37 years. I urge you to oppose House Bill 1584 because of the burden that will be placed on school nurses and because it's unnecessary, as there's already an RSA in place to codify medical and religious exemptions into law. I've been a UNH faculty for public health and community health nursing, supervising students placed with school nurses all over the state. I can attest to the volume and complexity of the patient load of school nurses. In some schools, there may be 600 students plus faculty and only 2 nurses responsible for their health and well-being. Having a standardized form for parents to express their right for their children to be exempt from immunizations for school entry is practical and useful. And while the parent is not required to complete the section that identifies which vaccine the child is exempt from, this is extremely useful information in the event of a disease outbreak in managing a response. I refer you to RSA 141C, Communicable Disease section, which clearly identifies the process for medical and religious exemption. House Bill 1584 will change the process for communicating medical and religious exemptions for immunizations once again, making it more complicated for school nurses to track and add costs by requiring notification of exemptions. It's unnecessary, and there is no benefit to the health and well-being of New Hampshire citizens. Thank you for your consideration.
Okay. Thank you. Representative Palazzo, are you taking questions?
Yes, please.
Yes, Representative Palazzo.
Thank you, Mr. Chan. Thank you for taking my question. Do you understand correctly that nurses are effectively acting as agents of the Department of Health and Human Services because they're not directly listed on this bill? So on page 1, line 27, we see officer, employer, or agent. So would you say that nurses are agents?
I'm not saying that. Nurses are there caring for students in schools.
Follow up. Could you clarify where exactly in this bill it touches or adds additional responsibilities for specifically for school nurses?
So I'm referring to the process of standardization, having one form that's standardized, collecting the same information from all families.
Thank you.
Anyone else? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question.
Mm-hmm.
So we heard testimony earlier from the department that they're sending communication down to the schools, down to the nurses, that these are the availability to have exemptions for medical, for religious. So are you aware, as a representative of the Nursing Association, is there a legal requirement that that information of the availability of the exemptions be passed on to people? So they're being informed by the department, but is there a requirement that you actually pass it on to the patients already in law?
Nurses are advocates for all of their patients, and they inform patients of all of their rights and responsibilities, and they are experts in their field. So I am fully, and I'm sure that nurses who work in the schools are fully competent and professional and experts in that area and understand the laws that apply to their setting.
But you don't have any knowledge of any specific law that states that this must be communicated.
No, I don't think so, but I don't think there's any specific law that says that anything in particular is that needs to be explained to patients.
Okay.
Nurses understand within the settings that they're working the laws that apply in that area.
Okay. So, to the best of your, sorry, Mr. Fierro. So, just to kind of clarify, so as far as you're aware, right now there is no requirement in law that they have to pass on the communication that these exemptions exist. But you're not certain, so okay. Okay.
I'm not working in this setting right now. Like I said, I've had students there, but I'm not aware of a law that requires that in particular.
All right. Thank you very much.
Representative McGrath.
Thank you, Mr. Chair. Thank you for taking my question. Is it true, as it says on this form, that in the event of an outbreak of vaccine-preventable disease for which an immunization is required, an exempt student shall be excluded from school attendance?
I'm not able to answer that question because I think that it would be something that would be decided between the department and the school in terms of the outbreak management.
Okay, see no one else? Okay, thank you very much.
Thank you.
Also signed up to speak is Kate Fry from New Futures, and you've asked for 3 minutes.
Good morning and Happy New Year, and I'll be even less than that. You'll be happy to know I'm Kate Fry, I'm the Vice President of Advocacy at New Futures, an organization that works on health and wellness policies in New Hampshire. Pretty much every issue that I had about this bill have been raised, about it being overly broad. It sounds like I'm not exactly an expert in the form process, but it does sound like there are issues with that as well. And as we know, 358 was vetoed last year. But more concerning to me was the penalty for employees of the state at a time when we really have a workforce shortage. Language like this can be very divisive, and I agree. I am not aware of other statutes who that have this regarding the penalty. This punitive penalty in the statute for employees.
Okay, thank you. Any questions? Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. I wonder if you can help me with understanding the word agent on first page, line 27. Do you think it would involve school nurses as being penalized, or would some other non-government organizations such as your New Futures would qualify as an agent of the Department of Health and Human Services for the purpose of this bill?
No, I read these as department staff would be affected by that. I can't speak to school nurses, and New Futures I don't think would fall under this because we're not affiliated with the state at all. But it's very clear that it sounds like department employees.
Thank you.
I see no one else. Okay, thank you very much. Also signed up to speak is Victoria Gullah from Spofford, New Hampshire. Hopefully I pronounced your last name correctly. Oh, okay, well, that's a good. You've asked for 3 minutes.
Can I just...
Sure, Representative Delemus.
Hi, I'm sorry. I just would like, if anyone has written testimony, would really be helpful. If you could turn it in when you're done with your testimony, would be great. Thank you.
Go ahead. Yeah, you have to hit the button. There you go.
Hi. Thanks for having me. I just wanted to make, while I'm listening, because I came here for a different bill, to say a few things. I have 2 kids who are in school, a son who's about to be 13 and an 8-year-old. And when you're a parent and you get these, and I was already informed when my child was going to be going to school, the forms that we get, there's nothing on them. We're not getting information from the state of New Hampshire. We're getting them from our schools or camps. So all these people who think the bill is too broad, I think it's too narrow. I think this should also be put on anyone who's requesting a vaccine to give the parents a full informed consent and transparency of what the laws are. Because most of the things you sign up online, and all the camps, I've signed my kids up for many camps, sports, Keene Rec Department, Chesterfield Rec Department. Actually, Chesterfield doesn't have it, but there are a lot that require a health form, and anyone who's requiring your health form, it says required vaccinations. And so the parent doesn't know that they have these exemptions. And I know this because I talk to other parents, and it's a pain in the neck because there's no process when you're online. It's like, you might not agree to something in the sign up forms when you go to your doctor's appointment, and you want to just cross it out and be like, okay, I'll agree to all this, and I want to cross this out and initial it that I don't agree to this. You can't. Everything's online, and if you don't do that step online, you can't progress to the next step online. And when you're trying to get your kid into camp, they fill up. Like in March, I was there, and it opens at 9 o'clock in the morning, and I'm there pressing the button to register my kid for camp, and it's already filling up. So you're trying to do all this stuff, and then all of a sudden now you don't have any way to know that you're exempt from these vaccinations, that you have a right not to have your child injected with these foreign materials. And for me, being pro-life, nobody informed me that any of these had abortal fetal cells in them, and that's just disgusting. And you just get no informed consent. One of the gentlemen here about the polio stuff, he goes, oh, well, they don't know the risk. That's all you get from the doctor's office. I asked on all the vaccines and if it was really necessary. And all they tell you is the risk of not getting the vaccine. They never tell you the risk of getting the vaccine, ever. And when I was in New York City with my first, it was a big practice. I saw a different nurse or a different doctor all the time. They never, not one, not here in New Hampshire, ever. So to say they don't tell you the risk of the disease, that is BS. Ask any parent. So please, I would consider making this bill more broad. And the reason that, I know the buzzer went, finish.
Stop wrapping up.
Yeah, the reason the penalty is in there is because there have been a slew of bills that this legislature has tried to pass on many subject areas. There is no enforcement mechanism. And citizens are really frustrated, and I thank the people who wrote this bill for putting an enforcement measure in there. There has to have some teeth behind it, because parents are sick of getting lied to, especially after they have an injured child, like my child with Tourette's.
Thank you very much.
Is that testimony?
Is that-
The paper?
Are there any questions for Representative McLean?
No, I'm sorry, I didn't write anything down.
Okay.
So,
sorry, sir.
And thank you for taking my question. So,
yeah.
In terms of trying to understand what direction to go in with this bill, all of these forms that you're being asked to fill out, where you basically, I cannot opt out because it's an electronic form and it's checkbox, checkbox, checkbox. But are those forms from the department, or are those forms being generated by the camp, the school, the other organization? You know what I'm saying? Because this bill just looks at what's coming from the department, and if they're informing the people who are providing the vaccine, I just don't know. So who is originating these forms? Just talk a little bit about that.
I'm sure they're following the state law and that about required, or, you know, the state law says that these are required of parents to get your kids vaccinated if you're a parent. They don't, none of it says anything about exemptions. So I'm sure that these organizations with their health forms, whether it's a public school or a camp or a rec center or daycare, are using that guidance, but there's nothing in there about exemptions. You're only told that these are the forms and these are the requirements. The same thing is with the doctor's appointment. I went crazy trying to get the poor school nurse was calling me like every month because I wouldn't put masks on my kids. And when I was getting my daughter into school, I didn't have a baseline a doctor's appointment from her since before she was 2. And so that was 2022, 23. And finally in the spring, the mask requirement came down. And so I was able to bring her for her annual exam finally in May, right before school ended. And the nurse was about to kill me. She was very sympathetic and she understood. But if you call all these doctors' reports up, but then I find out, so she's after me to get a doctor's appointment. But then I find out, like, I have another friend and she doesn't bring her kids to the doctor at all. And she's like, oh, just do a religious exemption. I'm like, for the doctor's appointment, for the baseline, you can do that too? And because she has her kids in the same camps as I do. And the camps say they require the doctor's appointment, like a baseline, I guess, before they're 6 or before they enter school. And I'm like, how did you do that? And she's like, oh, just religious exemption. I'm like, really? I didn't know that. And so I didn't even know that one. And, and the doctor, the nurse, the school nurse, who was very sympathetic to me, and had the same beliefs on that as I did, but still she felt that she was compelled to do this and didn't even say, oh, you can do a religious exemption like you do on the others. So there's just lack of information out there, and then not the ability when you're doing these online forms. They don't give you that opportunity.
So quick follow-up.
So which is coercion, by the way.
So
it is, right?
Well, I'll waive judgment for the moment, but if I may have a quick follow-up. So, has it been your experience in having these discussions that the discussion about the exemption and the availability of this form is something that they are offering up front, or is it something that is only being offered in your experience now when you ask the question? So if you don't ask the question, it's not brought up. So it's not something that's proactively offered.
It's never proactive.
Thank you. Representative Palazzo, you have a question? No, okay. Representative McGrath.
Mr. Chair, can I ask a question of the main sponsor?
She's already testified. You can follow up on afterwards, but she's already spoken. So, anyone else? Seeing no one, thank you.
Okay, thanks.
All right, no one else has signed up to speak on HB 1584 FN, so I'm going to close. Oh. Do you have a pink card or? Sit down. Okay, we have Larissa Trexler from Health Freedom, New Hampshire. 3 minutes.
Do I have to press this? Oh, you good?
You do, yes. So the red light is on, yes. There you go.
My name is Larissa Trexler. I'm a registered nurse, and I represent Health Freedom, New Hampshire. The statute 141C20C, it currently states that a parent or legal guardian shall sign a form stating that the child has not been immunized because of religious beliefs. I bring that up because until 2022, that was how we were practicing. It was just signing a statement. It's a very simple statement. The new DHHS form was slid in only when the ask was just for notarization requirement being removed. And prior to July 2022, parents could just submit the simple statement. It was one and done. It existed for years, many years, as long as that was the beliefs of the family. And it did not have the vaccination specificity. It did not have the grade level requirement, which sets up the impetus for expiration and for school nurses rejecting the form. And that is happening, rejecting the form and requiring the new form and requiring this annually because it says grade level on it. So, so that's one of the unanticipated side effects of this form. We're talking about a religious right, the exemption. It's intended for parents to be able to exercise their right, and there really shouldn't be any hoops they have to jump through. Those are new. It's not an ask, it's just a statement. A school nurse would need, and so there was a testimony about nurses needing to look at the child's immunization. Well, they would check off a box, and then we would somehow magically know from the exemption form that they had been, say, vaccinated for polio or up to date on polio. That exemption form is not going to give you that information. You're going to need to go to the child's medical records, so it's a moot point there. I think that's really all I wanted to touch on today. Thank you.
Okay. Any questions? Representative McLean.
Thank you, Mr. Chair. So I just wanted to get some clarity because the lady from the New Hampshire Nurses Association wasn't clear. Is there a requirement, and you may or may not know this, but as a registered nurse, maybe you do, is there a requirement for those administering the vaccines that they notify the people receiving the vaccines that they have the right to a religious or medical exemption? Is that a requirement that discussion happen?
I'm not positive. Like, I think the requirement would need to be specifically in statute, and I'm not positive that that's there.
So Mr. Chair, so is there a form or anything that is provided as part of getting the vaccination that contains something that you have the right to an exemption?
No.
So it's your understanding that there's nothing structural. I mean, it may happen, it may not happen, but there's nothing structural in the communication at the actual point of delivery. Okay, thank you.
Okay, seeing no one else, thank you very much.
Can I have your little notes? I can send you my notes.
Thank you very much.
Thank you.
Okay, I believe that was the last person to testify on HB 1584 FN, so I'm going to close the public hearing and open the public hearing on HB 1719 FN. And welcome back our Representative Potenza, who is also the prime sponsor of that one. Thank you, Representative Hartnett, for changing the sign.
I need a minute anyway.
I was wondering who did the first one. Did you do the first one also?
I did not.
Okay, probably. Exactly. can proceed anytime, my representative.
Thank you. Just for the record again, Representative Kelly Potenza, Stratford District 19. The title, of course, of this is removing hepatitis B from the list of diseases for which immunization is required or mandated in a sense under state law. Chair and Vice Chair, members of the committee, thank you again for the opportunity for me to introduce this very important legislation. So this bill restores New Hampshire's long-standing practice of following the Advisory Committee on Immunization Practices, the ACIP, recommendations and avoids imposing broader vaccine mandates than those supported at the federal level. New Hampshire has historically followed CDC and ACIP guidance for decades and has not independently expanded childhood vaccine requirements beyond those standards. In December of 2025, the ACIP voted to end the universal birth dose recommendation for hepatitis B for infants born, and then of course for infants born to hepatitis B negative mothers, and instead shifted the individualized risk-based decision making onto, of course, the parents. This bill simply aligns state policy with that updated guidance. Hepatitis B was created for high-risk groups like prostitutes and drug addicts. It didn't sell well enough to these groups, so they actually shifted this to infants because of the tiny risk to hepatitis B positive mothers' babies. Hepatitis B is not a disease that spreads through casual childhood contact. It is transmitted primarily through blood exposure, sexual contact, or perinatally from an infected mother at birth. All pregnant women in New Hampshire are routinely screened for hepatitis B. Therefore, the only meaningful risk to a newborn exists when the mother tests positive, and in those cases, vaccination remains strongly recommended and unaffected by this bill. For infants born to mothers who test negative, the risk is negligible. Universal vaccination in this context is a policy preference rather than a medical necessity. Many developed countries rely on prenatal screening and targeted vaccination rather than universal infant hepatitis B mandates, and do not experience higher childhood hepatitis B infection or mortality rates. That's fact. This legislation does not ban hepatitis B vaccination. It preserves access, respects parental consent, and restores individualized medical decision-making consistent with evidence-based public health policy. So New Hampshire has always followed, like I said before, the ACIP and CDC guidance on vaccines until now. If you haven't looked, the department immediately upon these changes that have taken place at the ACIP and the CDC came out with a public statement, notice, and letter basically saying they are going to ignore the guidance of the top medical experts in the country. The department then immediately changed their website, which has always, for years and years, been linking to the CDC for all vaccine-related schedules and information. So now, if you visit the New Hampshire Department of Health and Human Services website, so it's on their main page, it's home, programs and services, disease prevention, and the main page is called the New Hampshire Immunization Program. It has 13 quick link boxes, okay? So if you click on the box that has birth through 18, then there's some information on there. So it has one, vaccines for your children. Everything you need to know about routinely recommending childhood vaccines, including recommended childhood and adolescent immunization schedule for 18 years or older. That's a hyperlink. Then another hyperlink, why vaccinate? Another hyperlink, vaccine preventable diseases. Another hyperlink, vaccine safety. The history of this, I have spent so much time on this website over the years, is unbelievable. They have stripped every bit of the CDC off the website. Every single one of these links that I just told you, all links to the first one is the American Academy of Pediatrics recommended child and adolescent immunization schedule can be found here. And it has vaccines that are recommended on there that this committee has heard for several years now, where the department has said that they don't recommend COVID vaccines for children, which has actually been removed off of that CDC schedule as well. That's all listed on here, recommending 6 months and on for COVID vaccines for children. Then we keep going. Why vaccinate? FamilyDoctor.org. That is through the American Academy of Family Physicians. Vaccine preventable diseases and vaccine safety both go. And by the way, the copyright of these websites was 2026. They put these websites out immediately after that decision came from the federal government. And those are through the American Academy of Pediatrics. So now, I can't find anything really on the DHHS website in this whole section under vaccines and immunization specifically that links to the federal government, the CDC, which the department has religiously and diligently followed since inception. And they hung on every word that the CD said during COVID. We all remember that. How much federal funding does DHH receive to operate their agency? Probably well over 50%, or I don't know, from the federal government for them to operate. So I find it really interesting that they now want to bite the hand that feeds them or buck the system that they have followed forever because they don't like what the science has provided to the American people. This bill continues the tradition by aligning state law with the ACIP's and the CDC's updated hepatitis B recommendation. Again, hepatitis B is transmitted through blood and sexual contact or from an infected mother at birth. It is not spread through everyday childhood interaction. All pregnant women are already screened. So the only infants at risk are those born to hepatitis B positive mothers, and vaccination for those infants remain fully recommended. This bill does not prevent vaccination. It restores individual decision-making where no risk exists and ensures mandates are evidence-based, targeted, and appropriate. I wasn't going to talk about this, but I am. My daughter, who's 18, is vaccine injured from the Hep B at birth. I had zero informed consent. It was my first baby, and it has been her lifetime of debility. But I'm not coming from that. I'm coming from finally the truth coming out. I never signed any informed consent. I never signed off a form in the hospital. I had no idea that they took my baby that was 24 hours old and gave her that injection. And she has suffered greatly her entire life from the time I took her home from the hospital. So this is near and dear to me. There's many people on this committee that know because I've been very, very public about it for a long time. But I can talk about hepatitis B stuff all day long. But what I just said here is what needs to happen in New Hampshire, and it cannot be mandated and on the schedule any longer. Thank you.
Thank you. Questions? Representative Palmer.
So this is just a fairly simple question, I think, which is, what if the ACIP puts the hepatitis B back on their recommended list next year? So my question would be, why not have a bill that says that the state of New Hampshire will only have the vaccines that are on that list rather than picking out specific vaccines where it's going to be a fluid thing, and who knows where that's going to be years down the road, and now we have to write new laws to make our schedule compliant with that, rather than simply saying that our schedule should comply with that if you're going to make a law that way. Not that I'm advocating that necessarily, but I'm just curious.
Yeah, I don't think we should be following any guidelines at all. I think where there is risk, there needs to be choice. There should be no mandates at all. And when you give people the information and informed consent, and when you give them choice, they can make those choices. So that's really what it comes down to. People don't know any of the risks of that hepatitis B vaccine. They don't. And so to eradicate a sexually transmitted disease and to put a lot of money in Big Pharma's pockets, yeah, that's just a no-go for me. Like, I don't want to follow any schedule. There should be no mandates at all. There can be recommendations. There can be tons of documents that you know, on that side of the argument, that's all great, fine and dandy. It can be all over the place, but you can't mandate. Where there is risk, there needs to be choice.
Representative Markell.
Yes, thank you, Mr. Chairman. Thank you for taking my question. Can you tell us a little bit about the risks of the hepatitis B vaccine that I think you just referred to?
Yeah, I'm not prepared to go there right now. If you want me to send you all of that, so basically, hepatitis B gives most of the folks that are vaccine injured from the hepatitis B are from many toxins that are included in the shot, but the one that I believe injured my daughter is from the aluminum. The toxic level of an aluminum that went into her being less than 24 hours a year old. I mean, that is just unbelievable. It crosses the blood-brain barrier. It causes a slew of issues. Neuro issues. My daughter couldn't take, you know, she had feeding issues. I mean, she threw up pretty much almost every day for the first 6 years of her life. And she has a debilitating feeding disorder now. And I don't know if she's going to overcome that. So we are talking about like a crazy amount of injuries besides, of course, just death. So yeah, you can't, toxic levels of aluminum have caused a lot of that. And sometimes it's just a matter of shaking, you know, a little vaccine that, a little vial that might have, like, I don't even know, the nurse could tell you this better than I can. Some of them have like 5 doses in it, so they use it 5 different times. And you have to make sure that that is shaken up. If you don't, the aluminum and some of the toxins will sit right at the bottom of the vial. And so somebody can get a toxic dose just because someone didn't shake it enough. So there's just a lot of different things. I could talk all day long, but why are we wanting to inject healthy, beautiful babies that have a brand new immune system with basically a disease for, you know, sexually transmitted disease? It just doesn't make sense. And I'll scream about that all day long.
Thank you.
Okay, I'm seeing no other questions. Thank you, Representative Potenza.
Representative Potenza, do you have your written? Thank you.
Also signed up to speak, Dr. Benjamin Chan and Megan Hetty from the Department of Health and Human Services. And once again, you're looking for a total of 5 minutes for the two of you, I believe. Don't forget to put the mic, there you go.
All right, good morning, Chairman McDonald and members of the committee. My name is Megan Hetty. I am a registered nurse and the chief of the Bureau of Infectious Disease Control with the Department of Health and Human Services, Division of Public Health. I am joined today by Dr. Benjamin Chan, who is an infectious disease physician and New Hampshire state epidemiologist. Legislation would remove the hepatitis B vaccine from requirements for school and child care entry, increasing the risk of preventable communicable disease in our schools and communities, and making New Hampshire only the 3rd state in the country without a hepatitis B vaccine requirement. New Hampshire already has an established process under RSA 141C20C that allows for medical and religious exemptions for families who wish to pursue it. Vaccine requirements for school and child care facilities do protect children from diseases that can spread easily, cause outbreaks, and lead to serious infections or health complications. Hepatitis B specifically is caused by a virus called the hepatitis B virus. This virus is spread from person to person through exposure through blood and other bodily fluids. So transmission is possible in schools and child care settings through scratching, biting, cuts or scrapes that are accidentally share bodily fluids. These infections can then lead to serious health impacts like liver inflammation, cirrhosis, liver failure, liver cancer, and early death. And I'll hand it off to Dr. Chan in a moment to speak more to these items. But just as a last point here, for House Bill 1719 could also have adverse financial impacts for schools and child care agencies and parents and guardians of sick or exposed children that may need to be excluded from schools or child care settings. We also estimate that a single outbreak response could cost $100,000 to $350,000. And again, to reiterate, that's just a single outbreak. I'll pass it over to Dr. Chan for more info.
Yeah, Mr. Chair, members of the committee, thank you again for the opportunity to come testify before you on House Bill 1719. I want to just highlight maybe a few clinical points and then respond to a couple of Representative Potenza's comments about our reference to ACIP. But the hepatitis B virus is incredibly infectious. It's been estimated to be 50 to 100 times more easily transmitted through the bloodborne exposure route than other viruses that you may be familiar with, like HIV, the virus that causes AIDS. So very, very infectious. And it's not just transmitted through lifestyle activities or from mother to baby, for example, but can be very easily transmitted in household settings where other people in the household might have a hepatitis B virus infection. People can develop chronic, lifelong infections. The risk of a chronic infection is higher the younger that somebody acquires the disease. So infants who acquire hepatitis B infection have a 90% chance of going on to develop a chronic infection. And children with chronic hepatitis B infections, 25% are estimated to go on to die prematurely from liver cirrhosis, a liver cancer as examples. So this is not an inconsequential infection. And the hepatitis B vaccine is a highly effective vaccine. It's a 3-dose series. The 3 doses are estimated to give protection of around 98%, and that protection is believed to be decades, if not lifelong. Relative to Representative Potenza's reference to our following ACIP guidance, I just want to clarify that I think even in past years when this same or similar bill has come up, we have been asked about medical guidance that we followed. And I believe, if my memory serves me correctly, our response has been that we follow what we believe are the best evidence-based guidance and recommendations. Historically, that has been CDC's Advisory Committee on Immunization Practices, which has been in alignment with the American Academy of Pediatrics, which has been in alignment with the American Academy of Family Physicians. There has been a consistent evidence-based process that has been followed at a national and federal level that has brought all these organizations into alignment around medical recommendations. So what we've seen over the last year is that there has been a divergence or a split in terms of different organizations putting out different medical recommendations. And so the guidance put out by ACIP and the CDC no longer aligns with the AAP and AAFP. That's the American Academy of Pediatrics and the American Academy of Family Physicians. And so we believe at this time that the best evidence-based medical guidance that exists is that put out by AAP and AAFP, hence our recommendations that patients and providers continue to follow that guidance. So with that, I will end my comments. I know I'm over time, but I appreciate that there will be questions on this. Thank you.
Thank you. Yes, Representative Drew.
Thank you, Mr. Chairman. Dr. Chan, my first question is on the fiscal note that is attached to this bill. Make sure I got my numbers right here. According to data that I received from DHHS, DHHS purchases 2 hepatitis B vaccines, Recombavax from Merck and Engerix from GSK. Does that sound correct?
I'm going to defer to Megan on that question.
I would have to be able to get the specifics for you. I don't have them offhand at the moment.
Okay. We purchased, or DHHS purchases approximately 9,300 doses, according to the data that I received from DHHS. That costs DHHS approximately $158,000. Again, this is the data that I received from DHHS. So my question is, if we're spending that much, and we're buying that number of doses, and passing this bill will reduce that spending by $82,000, that appears to approximately be 50% of the doses. So is it the belief of your office that 50% of the women who are having children in New Hampshire are exposed to hepatitis B and should still get the vaccination? Or am I confused?
That 50% is to make sure that that vaccine is available for anyone who does want to be vaccinated. So yeah, we have to have some level of purchased hepatitis B vaccine to make that available for individuals. So that is the estimation, was the 50% for that.
Well,
Do you have any data on how many women are exposed to hepatitis B and would need to get the shot? Like, what are the rates of when people get screened, when pregnant women get screened for hepatitis B? What is the rate in New Hampshire that of the women who have hepatitis B would thus need the shot? Do you know?
So I think that's an important question, Representative. So thank you for asking that. We have some information, and I don't know the numbers off the top of my head, for the number of women who are pregnant who test positive. That is, I believe, required under the reportable disease rules to be reported to the New Hampshire Department of Health and Human Services. Hepatitis B infections in general, however, are not reportable diseases. I mean, we don't get reports of each and every person diagnosed with acute or chronic hepatitis B infection. And so we don't have a good idea about the incidence of acute infections or the prevalence of chronic infections in the state. That's something we're working on trying to address, so we have better reporting and better data. But I think it's also important to note that not every pregnant woman gets screened for hepatitis B for one reason or another. In fact, at a national level, I think the estimates have been that 18%, so 15 to 20% of pregnant women aren't screened for one reason or another. But it's also important, I think, to recognize that hepatitis B can be transmitted very easily in the home setting, not necessarily from the pregnant mother to the child or the mother to the child, but other family members who have hepatitis B can very easily transmit hepatitis B to others in the family. And so the childhood hepatitis B vaccination series is meant to protect the child from everybody that could be coming into the child's sphere and potentially transmitting the virus.
Representative Lamontagne.
Thank you, Mr. Chair, and thank you for taking my question. I understand hepatitis B is one of those diseases that people can be silent carriers. Could a pregnant woman carry the virus but test negative?
Thanks for that question. I think the short answer is yes, with some caveats. Obviously, there's it depends on what kind of test the pregnant mother gets and when they get the test. It's possible for there to be what we call false negative tests. So between the time when somebody's exposed to the virus and when they might test positive on the typical recommended screening test can be anywhere from 8 to 10 weeks, right? So if a pregnant mother is recently infected and then tested in that time frame and they test negative, they could later turn up positive, right? So there's a couple issues. One is that the pregnant mother doesn't get tested. Maybe they don't have access to health care. Maybe there's an oversight on the part of the medical provider. Maybe test results aren't communicated between the testing provider and the birth hospital, for example. But it's certainly also possible for somebody to test negative and then go on to develop hepatitis B infection later on for a variety of reasons. But generally, there are screening tests out there, but that's not 100% assurance that the baby's not going to be exposed or the infant's not going to be exposed to hepatitis B.
Representative Lucas.
Thank you, Mr. Chair, and thanks for taking my question. If a newborn is infected with hepatitis B as a result of vertical transmission from exposure to infected maternal fluids, and this leads to a 90% risk of lifelong chronic infection, severe liver disease, liver cancer, can you quantify the cost of health care for that infected individual, even though their life may be interrupted at an early age?
There definitely is a cost. What that would be, I think, is highly variable. But as I think we said before, infants that are infected early in life with hepatitis B, the majority will go on to develop chronic infection, 90%. And then of those chronically infected, 25% will die prematurely from liver cirrhosis, hepatocellular carcinoma, et cetera. And those kind of conditions have enormous financial costs, but the exact number we're not in a position to be able to estimate.
Follow up. Would one of the treatments potentially be a liver transplant?
Potentially, yes.
Thank you.
Representative Markell.
Thank you, Mr. Chairman. Thank you for taking my questions. Can you identify what just speaking to a prior question, what the risks of taking the vaccine are, and describe the major kinds of risks and what the likelihood of occurrence would be based on your knowledge?
So I guess maybe I'll address that in two ways. One is that there are vaccine information statements that are developed and encouraged, if not required, to be used for people getting vaccines. And so that kind of information about risks and benefits generally are outlined in publicly accessible ways on those types of informational sheets. It does not generally include information about conditions that people will, even in past hearings here in this committee, there have been assertions made that the hepatitis B is leading to hundreds or numbers of deaths, and that from our understanding simply isn't true. That's misquoting data and misunderstanding of data that's collected, like in VAERS, for example, on how it's used. But the hepatitis B vaccine has been in use it's universally recommended since 1991. It's led to us almost never seeing hepatitis B anymore, particularly in children. And it's considered a very, very safe vaccine. Generally, with these types of vaccines, the primary side effects, that you will see and hear about are local injection site reactions, infants' fussiness, and there's always a chance for anaphylactic or severe allergy-based reactions, but those tend to be very, very rare. So I know that there's different perspectives on this, but based on some of the science and the data that's out there about its use over the last 3 decades at this point, it's generally considered a very safe vaccine with very low risk of serious side effects.
Thank you.
Representative Mazer.
Yes, thank you for taking my question. So, yes, down in the methodology it mentions the estimated outbreak costs. When is the last time we had an outbreak of Hep B in New Hampshire?
Amongst children?
Anyone?
So we tend to have generally high vaccination rates. And I can't remember the last time we had an outbreak of hepatitis B, particularly in children. There have been some clusters that we've investigated over the years, more in adults. But I think that speaks as a testament to the effectiveness of the vaccine that, again, at least in the US, there's been a 99% reduction in hepatitis B infections because of universal hepatitis B vaccination. So we don't see them anymore because of the vaccine. Just a quick follow-up.
Follow-up, sure.
Yes, relating to that, you said you keep track of how many mothers test positive when they're pregnant. Moms test positive for Hep B. You mentioned not having the numbers right here, but can you get those numbers?
Absolutely, we can get those.
Thank you.
Representative Kesselring.
Thank you, Mr. Chairman, and thank you for taking my question. So you did mention that there could be other methodologies in the side effects of this or out there. Is there any other organization that you cited that has seen reverse side effects in the extremes? I'm just curious because you didn't really allude to that, but you did say it.
Well, thanks for that question and the opportunity to clarify. So I think what I was referring to before, at least and in past hearings on similar bills in the past, there have been comments and concerns that the hepatitis B vaccine is leading to children dying. And oftentimes the data that's quoted comes from VAERS, or the Vaccine Adverse Event Reporting System, which is a national system where any adverse event, any death after vaccination, whether or not it may or may not be related, is required to be reported into VAERS. But that data doesn't mean that, for example, the vaccine caused that, right? And so in terms of your question about is there any organization that collects information data about more serious side effects, I think that there's obviously the national systems, NERVS, VAERS, those are acronyms for national systems that monitor vaccine safety. And so there is data that's being collected and reviewed, but that just because data is collected in that system doesn't mean that, for example, somebody that died after a vaccination, it doesn't mean that the vaccine caused that death or that serious outcome.
Follow-up? Thank you. So I'm going back and forth here. So as a general public, if we were to tell a constituent that they're safe, how do we do that? Because you just basically said that there's no data reporting on it. How do we what's our baseline of information to do that?
Yeah, so thank you, and that's an important point in clarification. Again, I know that there has been discussion around this, but I think this is where patients that have concerns about vaccines should talk to their healthcare providers. I know that is not always a satisfactory experience for everybody, but there is information out there like the vaccine information statements that serve to help inform patients in particular about some of the main side effects from vaccines, any vaccine that's seen in the reporting systems, that's seen in the studies that are conducted on post-licensure vaccine safety. For providers, you have the FDA package inserts, which goes into much more clinical scientific detail about, what studies have found and side effects. That's not generally digestible for the general public. They're very dense and hard to read through, but there is information out there. And so the data that is being generated over years and decades, for example, with the hepatitis B vaccine, gets incorporated in that kind of informational sheets. Yeah.
Representative McLean.
Thank you, Mr. Chair. So I'm not opposed to vaccine mandates, although I do believe in a free society, the bar should be pretty high. So we talked about the individualized benefit of the vaccine. I wonder if you could maybe talk about where you see the societal benefit. And as you said, it's kind of hard for us to kind of put that in perspective because, you're saying this Hep B vaccine has been very effective. But if we were to look at hepatitis B, say from a historical perspective, so, before the vaccine came into existence, we all know about polio prior to the vaccine. We all know about measles prior to the vaccine. What is the historical landscape for hepatitis B relative to those diseases prior to the vaccine?
Thanks, Representative, for that question. So the societal and population benefit of the hepatitis B vaccine is the near elimination of the disease, particularly in our children. Hence, we don't see it hardly ever, and certainly not causing outbreaks in school and childcare settings. You referenced the polio vaccine and the measles vaccine. Those are examples where vaccination has led to the elimination of polio in the U.S. The measles vaccine has led to the elimination of measles in the U.S. since 2000. Now we're at risk in the next month of the U.S. losing measles elimination because of declining vaccination rates. But I would classify hepatitis B as the vaccine has high efficacy. To the point where it can potentially lead to near elimination of the disease, particularly in populations that have high vaccination rates.
So just a quick follow-up. So but I was wondering if you could kind of speak to the historical impact of hepatitis B prior to the vaccine. I think everybody in this committee is very aware of the historical impact of measles. We had Representative Nagel talk about the historical impact of polio. I don't hear about hepatitis B kind of on the same scale. So I'm just trying to understand, is that, are we just not aware of that, or indeed historically it was a real bad actor?
In terms of how common it was, I mean, we can get you some of those numbers. Again, particularly in children, since universal hepatitis B vaccination, there's been a 99% decline in hepatitis B infections in children. And so keep in mind, I think what I said earlier about, when infection occurs at a young age, there's a high rate and a high risk of chronic infection, and then a pretty high risk of chronic infection leading to liver disease, cirrhosis, death from, liver cancer. So those risks, were more in the past because of the higher rates of infection. But keep in mind that hepatitis B is not the only hepatitis virus out there that is capable of causing those complications. There's a hepatitis C virus for which we don't have a vaccine, but we do for hepatitis B, and so we can at least target improve population health and decrease these types of risks in our communities because we have the hepatitis B vaccine.
So just a final question to clarify. So prior to the vaccine, were we seeing hepatitis epidemics? Oh, I see Representative Palmer has his hand up. Maybe he has it.
I don't have the information about how commonly hepatitis B was transmitted in the school or child care populations right at hand, but certainly it was more prevalent.
Okay, Representative Polazov and then Representative McGrath.
And thank you for taking my question. Could you comment on your decision making, especially with regard to diseases primarily damaging adult population? You testified the department now believes in AAP recommendations, but AAP has terrible record when it comes to total disregard of negative risk-benefit analysis for COVID shots for infants and children, and it even more radical than previous position of the department that COVID mostly target elderly population, and for children and infants it shouldn't be so harshly recommended. So how do you decide to follow AAP now?
Thank you for that question. I guess I would just refer back to my earlier comments where, again, we believe that the American Academy of Pediatrics and the American Academy of Family Physicians currently have the best evidence-based guidance and recommendations. Those organizations used to be aligned with ACIP, but they have no longer aligned, at least in the last year. I will just additionally comment that we've been monitoring and paying attention to what's going on at a federal level and the recommendations coming from the federal government. We listen to all the ACIP meetings. We read the science and the evidence, or the rationale at least, that comes out from the federal government on their vaccine changes. And I think at the end of the day, and the bottom line is that no new evidence, no new science has been presented to justify the changes that have been made in the federal vaccine schedule. And so we still believe that the AAP and the AAFP remain the best evidence-based recommendations.
Representative McGrath.
Thank you, Mr. Chair. Thank you for taking my question. So you said there was a 99% decline. Are you able to provide us the number before and the number after? And the number before, so all of the children that you're referencing that had gotten the Hep B, and were they from Hep B positive mothers? Are you able to provide us that information?
Excuse me, sorry about that. That's a great question, Representative. I don't know that we have all that information. Certainly there are numbers at a national level. Looking at and reporting on the decline, we can certainly try and get you that information. Whether or not that data is connected with hepatitis B positive mothers, I'm not sure, and I want to say I don't think that it necessarily is. A lot of these numbers come from sort of national reporting of diseases, and we don't have access to the information about like the risk factors for why somebody ended up testing positive. But certainly there's data and information out there about the drop in incidence and prevalence of hepatitis B, but whether or not it's connected or the risk, whether or not it's connected to the risk factors, I'm not sure that we have that data.
Follow up.
So, in my brain, it seems that it would be from hepatitis B positive moms. You talk about how contagious it is. I remember when AIDS first came out and everybody assured the public that it wasn't contagious unless you were involved in risky activities. And so the ADA prohibits schools, including medical schools, from discriminating against students with hepatitis B. And the CDC guidelines is that chronic Hep B doesn't stop students from studying medicine or other fields. So if it's so contagious, how are the medical agencies allowing these students to be in these fields?
Well, thank you for that question. I think regarding protection of other healthcare workers, it's fairly universal that healthcare workers in general are required to be immunized to protect the healthcare staff and the healthcare system. Regarding transmission of a healthcare worker who has hepatitis B to patients, that's something I would have to sort of look into. I don't have a clear answer for you right now. I'm not sure what sort of institutional policies or occupational health recommendations might be out there to address that. So I don't have a clear, I think, good answer for you at the moment.
Seeing no other questions, so thank you very much.
Thank you. Thanks for your time.
For anyone here who is going to be testifying on HB 1784, we are behind schedule. It's going to be a while before we get to it, just to let you know. We're quite a bit behind. Next up to speak on 1719 is Representative Robert Wary from Hudson. Representative asked for 5 minutes. Given our schedule, I'd really appreciate it if you keep it to 3.
I will do my best, Mr. Chair.
I will have to ask you to keep it to 3, please.
All right. Thank you, Mr. Chair and honorable committee members. For the record, my name is Robert Wary. I have the privilege of representing Hillsborough District 13, the great town of Hudson. If I could speak on my credentials briefly, I have about 43 years experience in the pharmaceutical, biotech, medical device industries. I've researched, developed, and manufactured vaccines. In the mid-1990s, I worked on an AIDS vaccine with Dr. Jonas Salk, where I served as the head of quality for a manufacturing facility and conducted process engineering studies as well. I have a bachelor's in chemical engineering, master's of science in pharmaceutical quality from the University of Strathclyde in Glasgow, where I met the criteria for a qualified person as established by the Royal Society of Chemistry, master's of science in regulatory affairs from Northeastern University. I filed new drug applications, consulted on biologic license applications as well. I have a patent and taught industrial microbiology at the college level. I appreciate you listening to my testimony on this topic. On January 5th of this year, federal agencies made significant changes to the immunization schedule based on what the HHS described as comprehensive evidence-based assessment. They put the vaccines into 3 distinct categories: immunizations recommended for all children, immunizations recommended for certain high-risk groups or populations, immunization based on shared clinical decision-making. Hep B was placed into this last category of shared clinical decision-making. This tells us 2 facts immediately. One, by its exclusion from the first category, Hep B is not needed by all children since it wasn't recommended for all children. Second, by its exclusion from the second category, children do generally not fall into the classification of being within a high-risk group or population likely to contract hepatitis B. Let me discuss this last category about this shared clinical decision-making. What does this really mean? Ideally, it is the healthcare provider providing sufficient medical information about the risks and benefits or informed consent so that the parent or guardian may make an informed decision in the best interests of the child. The discussion should address the different following factors. I outlined 6, there's probably more, but how is it contracted? What's the child's risk of contracting Hep B? How long does the seroprotective elements provided by the immunization last? What adverse events are reported in the vaccine package inserts? How long did the clinical trial monitor patients for adverse events? And were there any additional significant adverse events reported through VAERS? All these factors should be considered to determine the risk of contracting the disease and reducing that risk by taking the vaccine, and whether or not that outweighs the potential risk of adverse events caused by the vaccine. So let me give you the conclusion up front. The risk of the adverse events caused by the vaccine appear to far outweigh the risk of contracting disease in New Hampshire. Therefore, I support this bill. I've written out the rest of my testimony where I go through line by line the examples of how those questions that I outlined should be answered by the medical provider. And this is the kind of informed consent that New Hampshire needs to protect its children. So, am I against Hep B vaccines? No. Test expectant mothers for Hep B infection and maybe vaccinate those infants. But
Representative, would you be able to give us a copy of that written testimony?
It is circulating, sir.
That's what you're...
Yes. So, at that point, I thank you for your time. I will be glad to try and answer any questions. I've tried to keep it down as short as possible.
Okay, thank you. I appreciate that. Any questions? Yes, Representative Drew.
So I'm going to read real quick from the CDC package insert on Recomavax, which is one of the vaccines that New Hampshire purchases and distributes. The following additional adverse reactions have been reported with the use of the marketed vaccine. Because these reactions are reported voluntarily from a population of uncertain size, it is not possible to reliably estimate their frequency or establish a causal relationship to a vaccine exposure. And there's a long list, including hypersensitivity reactions, including anaphylactic, anaphylactoid reactions. And then it goes down to nervous system disorders, Guillain-Barré syndrome, multiple sclerosis, exacerbation of multiple sclerosis, myelitis, including transverse myelitis, seizure, febrile seizure. So, in your experience with developing and testing vaccines, do you think that these companies are adequately following the outcomes of the patients who receive these vaccines? Because the fact that they're claiming that they can't tell because it's being reported, but yet the list of things that are being reported are a number of things that I would consider to be significantly worse than hepatitis B infection. So what would you say? Do you believe that the drug companies are adequately following the outcomes for patients in the current research?
Yeah, thank you for your question. The vaccine package inserts answer that question. They specifically say, I think I actually have it in the comments here, about halfway down, how long did the clinical trials monitor patients for adverse events? Intergex reported that they monitored for a total of 4 days after the final injection. Recombivax monitored 25% better for 5 days. That is, in the number of clinical trials that I've been involved with and have audited and seen in my 43 years, that's underwhelmingly low. Underwhelmingly low.
Okay, other questions? Representative McLean?
Yes, thank you, Mr. Chair, and thank you for taking my question. So I want to talk a little bit to the written testimony on the back page where you're talking, about the risk and how it's spreaded. So we heard testimony that this is an incredibly infectious disease and that it can, go right through the household. But in your written testimony here, you're talking about shared needles, things of this nature. So I'm trying to kind of put that together. So I guess if we envision a world where we don't have the hepatitis B vaccine, what is the real risk that we're looking at? And I'm still trying to figure out where that plays out in comparison to measles, in comparison to with polio. What are we talking about in terms of societal impact?
Thank you for your question. The CDC, I think I have it on this sheet here. The CDC in 2024 for New Hampshire recorded 14 chronic cases of hepatitis B and a relatively low incident rate on it. I think the numbers are published there. I can't do the math in my head, but you can calculate approximately how much there. So the risk of infection in New Hampshire is very, very low.
I understand that, but that's because we have the vaccine now. What I guess what I'm trying to understand is prior to the vaccine, what were we looking at? What is the real risk if we walk away from this vaccine? What is the real risk that we're talking about?
So I'll do this off the cuff, but based on the data I reviewed, there are certain areas where it is endemic, sub-Saharan Africa and some areas of Asia, where probably the Hep B vaccine, probably not at the infant level, but at some level would be appropriate. But if you look at the chronic cases in the U.S., and I remember looking at graphs and preparing for this, they started to rise in I believe it was the 80s. A lot of it was, as other people have testified to, due to shared needles as well as increase in sexual activity among certain groups, demographics. And once those groups were reached with prophylactic measures, you began to see a big drop. Now, does this correlate to the introduction of the vaccine? Causation is not, or what's the phrase?
Yeah.
Thank you. So, so I'm not sure that's accurate, but you see this drop occurring not just because of the vaccines, but because of the prophylactic efforts to address the populations and demographics where the disease is actually most prevalent. And it's those activities that seem to lead to the decrease in the overall rate of Hep B in the society.
Thank you.
Sure, Representative Mazur.
Yes, thank you. Real quick clarification. So,
Yes.
as a follow-up, this bill, though, does not mandate anything. It still makes the vaccine available. It just removes it from a mandate.
Right. Yes, it removes the yes.
So we're not
Thank you
walking
for your
away
question.
from Hep B.
No, we're not
Okay.
walking away. And as I say at the end of the testimony, test the expectant mothers. In those cases, I think that the risk and benefit are commensurate, right? It's these situations where for a bulk of these infants, the risks are minimal for contracting the disease, but the risks associated with taking the vaccine are actually incredibly high. And that's, I want the benefits to outweigh the risks, not the other way around. Thank you.
Okay, thank you, Representative Wary.
Thank you.
Also signed up to speak is Dr. Gwendolyn Gladstone from Exeter, from the New Hampshire chapter of the American Academy of Pediatrics. And again, I'll have to ask you to keep your testimony to 3 minutes, please. And did you have written testimony to distribute?
Yes, it'll be distributed
Okay.
to the members of the committee.
Okay. Yeah, thank you.
Thank you, Mr. Chairman. My name is Gwendolyn Gladstone. I'm a pediatrician. I'm a fellow of the American Academy of Pediatrics, past president of the New Hampshire chapter of the American Academy of Pediatrics, and I'm here representing that group today. Thank you for the opportunity to speak to this bill. Removing hepatitis B vaccine as a required one in the state of New Hampshire would be a disservice to the children in our state, to the adults in our state as well, and it would be bad fiscal policy. I finished medical school 50 years ago, and one of the first patients I had in my training was a child who'd been infected with hepatitis B at birth. He was in the hospital for weeks, very yellow. His ribs stuck out because he was malnourished, because he couldn't eat. He had a swollen abdomen from liver enlargement and fluid that accumulated from liver failure. And he died shortly thereafter of a completely preventable illness. Prior to 1991, the numbers of children so infected in America were approximately 20,000 per year. In 1991, hepatitis B vaccine was given routinely to all newborns rather than to just those whose mothers were known to be positive during pregnancy, and the rate dropped to a few dozen cases per year. That is why targeted vaccination doesn't work, because if you rely only on what you know about a pregnant woman's hepatitis B status, you miss thousands of children, nationally speaking. We have much better control in New Hampshire, but that's thanks to the fact that we have a good vaccine policy. And to abandon it would be to do a disservice to all these sick children. I want to just say that I disagree with prior speakers who have implied that it's a very unsafe vaccine. The common side effects from hepatitis B vaccine are local reactions like swelling and pain and redness around the site of the vaccine. For every 1.3 million doses, there is one case of anaphylaxis, which is a severe allergic reaction. That's the most common severe allergic reaction. So you can see that it's very safe, and we don't want to risk having children develop the infection. Many women in our country, unfortunately, do not get prenatal care, or they get prenatal care, and as Dr. Chan explained, they're not tested, or the test results are lost, or not reported, or reported incorrectly, or because health care is fragmented in our country, many women don't get the necessary follow-up care when they're known to be positive. That's why targeted vaccination doesn't work. I hear the bell ring. I will stop at this point. If anyone has questions, I'm happy to answer them.
Thank you very much. Representative Kesselring and then Representative Drew.
Thank you, Mr. Chairman. Thank you for taking my question. So the statistic that you cited about knowing the numbers, is that the CDC one that you're talking about?
Those data preceded the change in the ACIP recommendation. So yes, they were shared by ACIP, the American Academy of Pediatrics, by all scientific groups like that.
Okay, and that was something that was new? I'm just trying to make sure if that's like recent or if that's...
That's old. The 20,000 number is old data.
Okay, thank you.
Representative Drew.
Thank you, Mr. Chair. The child that you mentioned that was infected, how did that child get infected?
At birth.
How? Did it come from the mother?
Yes. The mother had hepatitis B and the child was infected at birth. And it wasn't known at the time the child was delivered.
Representative McLean.
Thank you, Mr. Chair, and thanks for taking my question. So you mentioned a very compelling statistic, 20,000 cases per year prior to 1991 versus dozens currently, if I wrote it down correctly. So are you aware of the 20,000 cases? Was that mostly that's adults and children?
No, that's children.
That's 20,000 children, and the bulk of those were obviously from birth then.
Correct.
Okay, thank you.
Representative Polazov.
Thank you, Mr. Chair, and thank you for taking my question. I have a question about AAP standards to considering vaccine safe and effective. your organization is infamous for recommending mRNA COVID shots to New Hampshire infants and children and ignore myocarditis and strokes in children. So I'm not sure, how can we trust your standards?
It is true that there is a risk of myocarditis, which is inflammation of the heart following COVID vaccine. Most of the people who get that complication recover fully. The risk is higher of myocarditis if you get COVID-19. So that is one reason why there is a benefit to getting a vaccine. No vaccine is perfect, no drug is perfect, everything has its potential side effects. That's why we talk about risk-benefit when we administer them to patients. And I'm sorry for the people who've been to healthcare providers where that didn't happen, it should. But there is a higher risk if you get COVID-19 than if you get the vaccine.
Is that appropriate? Okay, anyone else? Okay, thank you very much. Oh, I'm sorry, Representative Drew.
Thank you, Mr. Chair. So I look on the AAP's website, and you have corporate donors to AAP, and those corporate donors include both Merck and GlaxoSmithKline, who are both the manufacturers of the vaccines that New Hampshire uses. Do you see that as a conflict of interest? The fact that you're funded by the very people who are trying to sell the vaccines that you're recommending?
I'm not funded. The companies that support the American Academy of Pediatrics could potentially represent a conflict of interest. It's good to be public about it. That's why they put it on their website, so people will know and so that they can address that potential problem. I will say that the people who serve on the ACIP presently also have conflicts of interest. It's really hard to get away from them totally, but the American Academy of Pediatrics is very frank about it and addresses that directly.
Representative Kesselring.
Thank you, Mr. Chair. Just have a quick question. Do you know how many different vaccines New Hampshire uses for Hep B specifically, or how many different manufacturers?
I don't know the details about that, but I'm sure the people from the Public Health Department could tell you that.
Okay, I'm seeing no one else. Thank you very much. Also signed up to speak is Dr. Gary York from Hopkinton, New Hampshire. And again, sir, you've asked for 5 minutes. Please keep it to 3.
Yes, thank you. My name is Gary York. I'm from Hopkinton, New Hampshire, and I'm here to support the bill in front of us today. Before I came in, I was all excited to report the good news recently that we've obtained from Health and Human Services and CDC with their new recommendation schedule. That's what I passed around to you today. But I'm really in kind of a dour mood now, knowing that the New Hampshire Health and Human Services Department, for some reason, decides not to follow the CDC recommendations, as they did during COVID, where they had many missteps, as everyone knows. I don't know who makes those decisions in Health and Human Services in New Hampshire, but it needs looking into. I just want to go over this form for you, and I apologize. I should have handed out magnifying glasses to this group, but I did arrow the hepatitis B vaccine highlighted with an orange arrow. Basically, the esteemed Director of Health and Human Services, Jay Bhattacharya, working with others and consulting with others across the world, experts across the world, about their vaccine schedules. Significant is that the childhood recommendations for vaccines has decreased 70% from the current schedule. That's great news. That's great news. And to accommodate those people who can't believe that could be true, there are 3 tiers to the schedule as proposed by the CDC. And other speakers have talked about this before. there's a category for high-risk populations. And in that group, the population of women who are pregnant with positive testing for hepatitis B, it's recommended for infants to get that shot at birth. And now the third category is immunizations based on shared clinical decision-making. These are for people who are tried and true vaccine lovers, where they're going to just stick to the vaccine schedule. They just love vaccines, can't get enough of them. So that will be something where they're going to adopt probably the third category for things that are missing from the top schedule. So that's good news for me, but still I'm concerned about the stance of the New Hampshire HHS.
Could you start wrapping up, please?
I will. Most importantly, that the HHS would follow the recommendations of the American Academy of Pediatrics and the American Academy of Family Practice. Certainly, these practitioners make a not insignificant amount of money from giving vaccines. I don't know the numbers, but to me, that is a clear conflict of interest. And one last statement, people have talked about the safety of the vaccines. Everyone should know that all of the childhood vaccination schedule, vaccines on the vaccination schedule, none have been tested for the gold standard of placebo versus vaccine. None, zero. Thank you.
Thank you. Questions? Representative McLean.
Specifically, do you know why the CDC, in a specific case of hepatitis B, chose to remove it? I'm aware what I heard in the news that they were mirroring countries like Denmark, etc. But is that the extent of it, or there must be more?
No, it's called common sense, pure and simple. There are kids in the age groups that they're giving these vaccines to, the risk is so minimal that it doesn't make sense to give these injurious vaccines to these newborns straight out of the birth canal. It's ridiculous. This is common sense. None of the kids in school are going to be exposed to these kinds of high-risk behavior. No, I won't say none. Some of them may be involved in high-risk behavior. But we can educate parents and school kids, if you are in this high-risk behavior, you should be getting a Hep B vaccine.
Okay, I'm seeing no one else. Thank you. Also signed up to speak is Adam Weinstraub, I believe it is, from the New Hampshire Families for Vaccines. You've asked for 2 minutes, sir?
Yes.
Did I pronounce your name correctly?
Adam Weintraub.
Okay.
Thank you. Good almost afternoon. My name is Adam Weintraub. I'm here on behalf of New Hampshire Families for Vaccine, but I'm primarily here as a father, as a New Hampshire citizen, and I'm also as a lawyer. And in my job as a lawyer, I have to argue things one side or the other, and I'm presented with the same issues that you are, is that you don't know which way to go. And in my line of work, I have to rely on what experts tell me in order to advocate properly on behalf of my clients. And, the testimony that you've received here, I advise you to follow what the experts say. You've had an epidemiologist speak to you, you've had doctors speak to you, and they all advocate for this vaccine. And that's because you've had decades and decades and decades of this vaccine being given out across the nation, and it's been shown to be safe and effective. And you have a difficult decision in front of you, but in trying to make a difficult decision, the best thing you could do is rely on what the experts are telling you to do. And that's all I have to say.
Okay. Thank you. Before I go to any questions, I want to for the benefit of the committee, we're not going to take a formal lunch today. Members are encouraged to go at their leisure. We're going to keep going so that we can try to get back on schedule at some point. But thank you for your testimony. And Representative Meza, you have a question?
Yes, thank you. So the CDC, were they experts during COVID, but they're not now?
You know, it's not up to me to say. Again, I'm a lawyer, and what you should do is look at what the CDC is saying and what doctors are saying and what experts are saying, and that's the best way you're going to be able to make your decision. I'm not the one to tell you. Let the experts do that.
Representative Kesselring.
Thank you, Mr. Chair. Thank you for taking my question.
Sure.
So as a lawyer, would you say it's better to let the people make the decision themselves?
I would say that, you know, certainly people can make their own decisions, but we have decades of evidence showing that this is a really safe thing to do, and certainly you should be relying on what is shown to be safe and effective, evidence-based evidence.
Follow up.
Thank you for answering that question. So have you ever tried any cases for vaccine injuries or specific things like that?
I have not.
Representative Drew.
Thank you, Mr. Chair. New Hampshire Families for Vaccines. I'm looking on your website and it says paid for by American Families for Vaccines Action Fund. You are associated with American Families for Vaccines?
Well,
yes or no?
I was asked to come here on their behalf. I can't really answer that question, but I would, you know, if it's on the website, that's what it says.
Okay. And then you go to the American Families for Vaccines.org and you look at their partners, and their partners include both Merck and GSK.
Sure.
Which are the companies that make the vaccines that you're recommending. Is that correct?
Sure.
Do you see that as a conflict of interest?
I mean, the information's all there, and nobody's hiding anything.
Anyone else? Okay, thank you.
Thank you.
Also signed up to speak is Victoria Gulla from Spofford. And again, ma'am, if you could keep your testimony to 3 minutes.
Hi, Victoria Gulla from Spofford, New Hampshire. It's really hard to keep testimony to 3 minutes when you have Dr. Chan up here for 15 minutes live.
His testimony was not.
Yes.
His testimony
Yes,
was
there's
limited.
a lot of questions.
A lot of questions, yes.
Okay, let me get right to it then. So first of all, he's talking about outbreaks. Outbreaks are in nursing homes. The CDC was subpoenaed and sued for the information on a number of daycare settings that had outbreaks. Under a court order, they could find none in a daycare setting. That would be, you know, children under 6. They're in nursing homes for elderly people where they're doing very poor, like sharing glucose monitoring and things like that. So that's misinformation number one. It's hard. I'm trying to jot this stuff down so it's fast. Also, is it really safe and effective? How do you know? They study these vaccines for 4 to 5 days, and newborns can't tell you how they feel after that. When you go to the pediatrician now, speaking as a mother of 2 young children, the signs all over the office to alert parents to the dangers of purple crying. Do you all know what purple crying is? Do you know what shaken baby syndrome is? Your baby cries so much, and then they blame the parents on shaken baby syndrome of causing brain damage, brain hemorrhage, but it's probably from the vaccines, not from shaking the baby, because it's the same symptoms. So when they're saying it's safe and effective, they lie on other causes of injury. I repeatedly would call my pediatrician's office when my son would break out in hives after vaccination, high fevers. They didn't know what it was. They would say, what do you want to do? Do you want to talk to a nurse? Do you want to talk to the doctor? No, I'm just calling. It says on the information sheet to call. It says only 5% of kids get fevers from the vaccine. They don't record it. So this guy wants you to rely on experts, and with the data, they do not record it. You know, what's the first thing you learn about data? Garbage in, garbage out. They don't even put it in. It's just a lie. When I had my baby, in the hospital. He comes back with 2 Band-Aids on his legs. What's that for? Hep B. Why did you give that? Isn't that for like drug users or something? Oh, he can get that here in the hospital through a diaper change. That's a lie. And I know that now, 13 years later, because I know that the CDC has been subpoenaed and sued to get that information. Nothing in a daycare setting. They lie. So you want to rely on experts? They lie. They lie here. In this one over here with the COVID vaccine, it's all... we're not even on that. She's lying about the COVID vaccine and myocarditis. It's complete opposite of what she said. So, Denmark, the lies. So she says that that a targeted vaccination doesn't work. Denmark does not do vaccination of their babies unless the mother has hepatitis B. They have an infinitesimal amount of babies with Hep B or children that develop it. It's the same infinitesimal amount as here in the United States. So we're vaccinating all our babies, having them risk these awful side effects. And then in Denmark, they're only doing the mothers, and they have the same rates. I heard. I'm finishing. You wanted to know. I'm answering his question. He wants to know how much, what the prevalence is. Rep. McLean over here. Same as Denmark, where they do not vaccinate babies. It's like 0.0001. It's statistically 0. And that's with targeted. She says targeted doesn't work. Works in Denmark.
Thank you.
Can I have your testimony?
Well, I can write something and put it in.
Okay, thank you. That would be great.
And I wasn't even going to say that. You sit here and you listen to these people lie. It's very difficult.
Okay. Thank you, ma'am. Okay, also signed up to speak is Dr. Patricia Edwards from the Academy of Pediatrics, New Hampshire chapter. And you've asked for 3 minutes, ma'am.
Yes. Thank you, Chairman McDonald, members of the committee. I would like to read mine just to save time, okay? First, I will say I agree with the testimonies my colleagues have presented. I would like to take a look more at the financial medical burden. If we look back in time, and I have some answers for you, numbers. If we look back in time, in 1982, there were 20,000 cases of Hep B in children in the United States. At that time, there were 1,000 cases in the state of New Hampshire. In 1992, the total U.S. cases in children was still around 18,000. Remember, the vaccine program started in 1991, so 1992 had not gotten a chance to show a decrease in children because there were already infected children. But you could extrapolate that 18,000 would have been 900 cases in the state of New Hampshire in 1992. Enter the use of hepatitis B vaccine in newborns in 1991, and the total case of Hep B in children in the United States in by 2009 was 14. This is an amazing decrease in hepatitis B infections, and I can assume they were probably 0 in New Hampshire or 1. Sadly, as time has gone on, there has been increasing vaccine skepticism, leading to the 2017 numbers rising to 1,200 in the United States. Not a large number, but thereby showing us that protective measures are not necessarily the answer. What that means is that it's quite a savings for healthcare. Chronic treatment for hepatitis B costs from $1,000 to $3,000 per month for medications alone. This adds up to hundreds of thousands of dollars over a child's lifetime, not to mention possible hospitalizations, treatment for liver failure, and or liver cancer. In fact, one night in a pediatric ICU in New Hampshire can cost $3,000 to $5,000, and we're paying for that. When we consider that the cost of one hepatitis B vaccine is as low as $40, the whole 3-dose series can cost as little as $120. At the most, the cost rises to $400 for the series. There has already been a 99% decrease in hepatitis B infection since the introduction of the newborn hepatitis B dose since 1991. It seems to be a very poor financial decision to end this life-saving treatment, as well as an obvious detriment to children's health to deny this. As to parent choice, I do not like this word mandated. We do have a rule that children for school age, 5 years old and up, should be vaccinated, and some daycares have this also. However, as we've already been over, you can refuse to have your child vaccinated for hepatitis B in the hospital. And when I was rounding in the hospital, all my patients knew and had informed consent from the nurses, from me, from the OB about this vaccine. So I'm sorry if somebody didn't inform their parents. That was wrong. you don't have to have it for kindergarten. You can get an exemption, as we've already stated. And that's pretty much my thing, except as the live free or die state, all parents should have the right to the freedom to vaccinate their children also.
Thank you. Questions? Representative Drew.
Thank you, Mr. Chair. Of the 20,000 that were infected prior to the advent of the vaccine, how many of those were not caused by the infection being transmitted from a infected mother?
Sadly, I could not get those numbers. You know, a lot of states don't even keep records sometimes. I was surprised I could find the numbers from New Hampshire, quite frankly, because we're one of the often the states on the maps of diseases and all that's a white one, which means we have no statistics. Live free or die.
Representative Kesselring.
Thank you, Mr. Chair. Thank you for taking my question. Do you have any statistics to the time prior to the, I think it was like 1980s, around that time frame you quoted? It looks like that's when the Hep B injection started.
It was more prevalent, yeah.
So, well, that's when it started. It looks like for it. Now, do you have anything prior to that, the numbers between?
I did not look back that far, but I was a resident about that time, and I can tell you, resident doctor, we did see hepatitis B, and in my 40 years of practice as a non-resident doctor, real, you know, a practicing physician, what can I say? I have not, knock on wood, seen a case of it. Except in one family actually who came from another country, sorry, forgot them, Haiti.
Representative McGrath.
Thank you, Mr. Chair. Thank you for taking my question. Can you clarify, you used the numbers in New Hampshire of 1,000 and 900, went down to 14 children. Were the 1,000 to 900 children, or were they all?
Those were children. For some reason, in those 2 years, in that 1 year, the state of New Hampshire kept a record. And my 900 was extrapolated from what the, number of cases in the United States were. It probably went down a little bit because it went down a couple thousand in the United States.
Okay, thanks for the clarification.
Representative McLean.
Just quickly, we heard testimony, because you say, well, you don't have to vaccinate a newborn. But we heard testimony that a mother said she came in and she says, "Oh, what is this?" So this was vaccinated for hepatitis B. So is there anything structurally that is given to the parents in advance of the vaccines being delivered that they review? Could you maybe talk to that?
Yes, there should be, like Dr. Chan had said, the VAERS paperwork. And also they should have been discussed with the pediatrician who did the rounds on their child, I would think. And the nurses are usually very good at also giving information because the nurse gives the shot. So she usually will talk to the parent beforehand. So if that parent was not informed, that hospital was not doing its due diligence.
And I understand the term usually, but I'm just saying, is there some, and it should happen, but when something is it's usually done, sometimes it happens, sometimes it doesn't happen. So my question specifically is, are you aware of anything structural that is procedurally put in place to make certain that doesn't usually happen, that it'll always happen?
It's been a while since I rounded in the hospital and had my own children. I do believe I recall signing for all those things, and I do believe I remember people having to sign. In our in our office, we have it documented as a verbal discussion with the parent, and we have a check-off box for our vaccinations.
Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. Could you comment on previous testimonies that AAP is funded by the very two pharmaceutical organizations who promote these two drugs that were only clinically tested with follow-up 4 to 5 days and no placebo control study? For me, it doesn't sound like proper safety control.
Well, number one, I am not a person who knows everything that's going on in the AAP, and if they're transparent about it, that's the most you can ask for. They're telling you the truth that they're funded by them. What was the last part of your question? I'm sorry.
that these drugs, these vaccines that were recommended, we heard that safety control was not scientific, that there was no placebo control in safety research, that follow-up was only 4 days for one vaccine and 5 days for another, so it's not enough to catch some long-term side effects that parents are very worried about.
Well, actually, I believe vaccines are followed for years and years. I can't tell you exactly how often on the hepatitis B, but they do send out, you know, in the initial stages of it, paperwork or whatever to people to find out if they've had any problems. And we have the VAERS system where we can send in any severe issues that happen with children, and parents can report it themselves also. And as for saying placebo control, we're probably going to have some placebo control in the next few years as the vaccine rates go down and you see the disease rate go up. That'll be your placebo right there. And I don't think it's ethical to do a placebo trial on something that's already been well proven by studies and by information to now say, let's just not vaccinate this bunch of babies whose parents want them vaccinated and see what happens. That doesn't sound ethical to me or morally correct.
Okay, Representative Drew.
Thank you, Mr. Chair. Do you believe it would be ethical to mandate a vaccine with unknown side effects or without clear safety data?
Again, I don't like the word mandate. You have a right of refusal. You have a way to refuse it. You do not have to give it to your child if you do not want to. Mandated means you must give it. This is not the case. You can say, I don't want it at birth. We have some patients in our practice whose parents bring them in and at 2 months they get it done. Fine, that was their decision, their choice. They didn't want it at birth. They come into our office, have it at 2 months. That's their choice. They go to school, kindergarten, they do the medical exemption or the religious exemption in this state. They don't have to get it. They can go to school. And also remember, you have the choice to homeschool your child.
I'll follow up.
So you believe that the parent should have the choice over exactly what vaccinations their children get?
I believe the parent has the choice. And I believe it should be an informed choice. And I believe they should talk to someone like me so that they can make an informed choice. And I do not lie.
Representative Kesselring.
Thank you, Mr. Chair. Thank you for taking my question. Do you think, based on your testimony, that other nurses lie about this to make it so that they get the vaccines?
Ooh, that's a very interesting question. I don't think anyone lies for them to get the vaccine. I think there are some misinformation going around about the problems with the vaccines that are not true, that are misinformation. And I do believe there are some nurses who do spread misinformation. Yes, I do.
Representative Lamas.
Hi, thank you for taking my question. Thank you, Mr. Chair. So, on the tail of that statement, which I agree with, do you think that this bill would help with that so that we have a more information out there and a more clear, visually clear evidence that they can decline? I'm probably addressing the old bill.
Yeah, I'm not sure that's how this.
Yeah, no, that was the last bill.
Yeah. My biggest concern is that if this bill passes, that it will make the vaccine less available to the parents who want it, just like with all of the other recommendations coming out of the CDC, which, by the way, they are not medical experts on there anymore. There's a few. There's one from the Academy of Pediatrics, and he actually is opposed to most of these changes. But I am very concerned that you'll want it for your child, and the hospital will say, gee, we don't have enough of it here because, And so that takes away the rights of the parents who want to be vaccinated. And quite frankly, right at the moment in my practice, parents are coming in, and I had one the other day. you're not going to stop vaccinating our children, are you, Dr. Edwards? They're scared that I'm not going to vaccinate their children. To which I replied, no, we are going to, but where will it lead?
Okay. One last question, Representative Kesselring.
Thank you, Mr. Chair. I just wanted to address that comment you made. Are you concerned that there will be more confusion?
Oh, yes, definitely. There already is.
Okay.
My parents are scared. And, you know, as to terrible side effects and all that, been practicing for 40 years in the state of New Hampshire, right here in Concord. Literally see none of these bad side effects from the shot in children. A sore leg, maybe a fever.
Thank you,
and
Doctor.
hepatitis B, not much of anything, really.
Thank you very much.
Thank you.
Also signed up to speak is Larissa Trexler from Stoddard. And you have 3 minutes. You've indicated you want 3 minutes.
Thank you for taking my testimony. Larissa Trexler. And the first thing I want to do is read the statement from somebody that can't be here today. I'm going to summarize and then I'm going to forward you the longer part of it. Tara Hayfie of Brentwood, New Hampshire. I am unable to make it to today's hearing in person, but want to express my support for HB 1719 and the removal of the Hep B vaccine requirement. Young adults who received their Hep B shots as a baby may be unprotected by the time they are young adults. My daughter required a Hep B titer test in college prior to beginning clinical rotations within the medical field. She had 3 Hep B shots as a baby. At 19, her titer test came back with almost 0 antibodies. The college told her she needs 3 additional shots to get current before they can place her in clinicals. Due to a severe vaccine reaction, she has a medical exemption for all vaccines and was told they may not be able to place her unless she received the 3 additional hepatitis B shots. I'll send you guys the rest of that. And on my own testimony, I wanted to say that my oldest daughter had hepatitis B vaccination complications at birth at the hospital. We did continue to vaccinate our children, and when my youngest daughter was born in 2012, I declined the injection of hepatitis B at birth. We just wanted to delay to 2 months. That might ring a bell with prior testimony. But it was given at birth anyway, against our wishes. My child was vaccine injured and continues to have impaired liver function. She's a teenager now and jokes that her liver isn't livering. So I mentioned before, I'm a registered nurse. Well, I'll say as a mom, I have not seen true informed consent. As a nurse, I have not seen true informed consent. The general consensus is just saying that there may be a rash, a little redness at the site. They might sleep extra or be fussy. Sometimes there's a fever. That's all we were always instructed to say. There is a sheet that parents get when they're vaccinated in outpatient setting. I'm not sure about in the hospital. I didn't get anything. That's all I was going to say. Yeah, this is support for this.
Okay. Thank you.
Thank you.
Questions? Representative Palazzo.
Thank you, Mr. Chen. Thank you for taking my question. So when looking into financial implication of this bill, department was mostly concerned with price of the vaccines. There was also expressed some thoughts about price of possible outbreaks, but they gave no consideration to the cost of side effects. Do you think we should consider the cost of vaccine-injured children as well?
Absolutely. Ours are astronomical.
Okay. See no other questions. Thank you.
Thank you.
Also signed up to speak is Kate Fry from New Futures. And you've asked for 3 minutes.
Again, I'll give you much of that time back. I do have written testimony that I will leave with you before I go as well. We are opposed, I'm Kate Fry. I'm the Vice President of Advocacy at New Futures. We're a nonprofit, nonpartisan organization that works on health and wellness issues. We are opposed to this bill. I won't repeat a lot of what has been said already. I just wanted to get some information on what's come up about societal costs. And so it was established in a study from NIH that across just one birth cohort in 2009, the hepatitis B vaccine led to a savings of $250 million in direct costs, including medical expenses for treatment and complications. It also talks about the savings that you'd see from if there were lost productivity due to caregivers who were not able to attend. So I can get you that information. I also wanted to talk about just the societal costs that we have seen as of late. We know that immunizations are in place to keep our communities healthy, to keep kids going back to school, to keep families in regular routines with sports and all of that, and less missed sick days. And we've seen recently with COVID, even though this bill has nothing to do with that was greatly impacted. And one of the societal costs that we're really seeing is the mental health crisis we have with our young children. And that's a very significant societal effect. So I will leave you with that. One other thing that is related to this bill, as an organization that also works on substance use disorder issues, I find some of the language that has been used to describe people who have this disease is very stigmatizing. I've heard things like drug users, drug addicts. These are people with substance use disorder, so I just think it is important to use the correct language when we're talking about the people involved in this. And that's all I have.
Okay, thank you. Representative Drew.
You talked about the societal cost of the disease. Was there any information on the societal cost of the side effects of any of the vaccines?
I don't believe this is a snippet from the NIH study. I do not know offhand, but I can get you that study.
Follow up.
Do you believe that there are significant dangerous side effects from vaccines?
Personally, I will answer this as a mom. I do not. I'm more concerned about the the effects if my children did not get vaccines. I will say, as far as information being provided to parents, I had this is 22 years ago, and 2 kids very close in age, and we would leave the pediatrics office with stacks of paper around the concerns and informed information. And they were all in bright colors. We talked about maybe wallpapering our kids' walls with them, but we consistently got that information. It was provided to us, and so we have made always the decision to vaccinate our children.
Anyone else? Okay, seeing none, thank you. Also signed up to speak is Carleen Ferrier from the New Hampshire Nurses Association. And you've asked for 2 minutes.
Thank you, Mr. Chair and members of the committee. Again, I've been a nurse in New Hampshire primarily for 37 years. I've administered thousands of vaccines to patients. I'm a mother of 4 living children who are all vaccinated. Today I'm speaking to you on behalf of members of the Nurses Association, and I urge you to oppose 1719 because of the dangerous impact it will have on the health and well-being of New Hampshire citizens, particularly newborns and healthcare workers. Newborns have been immunized against hepatitis B since 1991, resulting in significant reductions in infection rates, with vaccines being 98% effective. The CDC reported 252 new chronic hepatitis B infections among people up to age 19, or 0.4 of every 100,000 children in 2022. Infants are particularly vulnerable to the virus, and 90% of those infected will develop chronic infection. Newborns respond well to birth dose of hepatitis B vaccine, and after completing the vaccine series, 98% of healthy infants achieve full immunity. The most common mode of transmission of hepatitis B is through childbirth. That's why the U.S. is not a global outlier in recommending hepatitis B vaccine for newborns. In September 2025, the CDC reported that of the 194 World Health Organization members, 116 countries recommended universal hepatitis B birth dose vaccinations in all newborns. The U.S. does not have universal health care, and therefore not all pregnant women have access to prenatal care. Therefore, there is often not time for testing and waiting for results. As you have heard, hepatitis B is a sneaky and hardy vaccine. Most people do not know they have contracted it, and they can remain asymptomatic. Hepatitis B can live on a surface up to a week and found in very small amounts of blood on nail clippers, razors, and toothbrushes. For these reasons, I ask you to protect the healthcare workers in New Hampshire and protect the babies. Any questions?
Thank you. Any questions?
I will share the testimony for this and the prior bill electronically because I have hyperlinks that you can access for the references.
Okay, great.
Thank
Thank you very much. Okay, and also signed up to speak is Dr. Christine Arsnow, I believe it is, from Concord, from the New Hampshire chapter of the American Academy of Pediatrics. How did I do with the last name?
Pretty good. I know
Okay.
everyone wants it to have
Arsnow?
in there. Arsnow.
Okay.
All right. Good
You
afternoon.
asked for 2 minutes, correct?
Okay.
Yeah.
2 minutes is great. Good morning or afternoon, Chairman McDonald and members of the committee. My name is Dr. Christine Arsnow. I'm a primary care pediatrician here in New Hampshire, and I am the president of our state chapter of the American Academy of Pediatrics. So I just want to gloss over some of the numbers. I'm passing something out here. I agree with my colleague's testimony prior. So, and just to be clear, in the 80s and 90s, you could get a Hep B vaccine. It was just targeted. It wasn't universal. And we saw about 20,000 cases of hepatitis B per year. So that's each year in kids under 10. After universal implementation of that vaccine, the numbers dropped dramatically. One thing I just want to touch on. So I am a primary care pediatrician. I talk to dozens of families every week, and families with young kids often don't have time to be at these things. I took a vacation day and I'm lucky to have a great babysitter, but I'm a mother of 3 young kids. I should also add that. But what I'm hearing, what families are saying is that they are so confused and overwhelmed by these changes. So, there's been the argument, okay, let's have the vaccine available, but just leave it completely up to families what they decide to do. This very morning before I came here, I saw a 2-month-old baby, and it was the mom's 3rd baby. Usually by the 3rd baby, people have things pretty much down. She was happy and sleep deprived, as they typically are. And she opened with, she said, Dr. Arsnow, I'm just so confused. I vaccinated my other 2 children because everyone, CDC and the AAP and the American Academy of Family, we all had the same rules back then. And after this 3rd baby was born, I'm seeing all this stuff in the news that the CDC changed their rules. And is there something new? As you asked Representative McLean, is there new information, new data about the hepatitis B vaccine? My point is, we need to have public guidance that advises family the right direction to take. Families should be able to make their own decisions. There are avenues to delay the hepatitis B vaccination or, choose ways to have an alternate vaccine schedule. But the public health guidance should be what is going to protect the most number of infants and children. And that is to have universal hepatitis B vaccine at birth. As our statistics clearly show, it reduces the rates of kids contracting Hep B and therefore going on to develop chronic liver disease.
We could start wrapping up.
That's
please.
all I have. I think the only other thing I was going to say is that to answer your question, as it has been answered, Representative McLean, there is no new data, there is no new information that prompted these changes. And so it's, when I talk to families, that's what I say. I say, well, last year everyone agreed, so that's what I would recommend, following those guidelines.
Thank you. Representative Drew.
Thank you, Mr. Chair. So if families should be able to choose, why does it need to be in the law?
It needs to be in the law because this As I understand it, this is for school immunization requirements and daycare immunization requirements. This is not a requirement for every newborn who is born. It's just a requirement for public spaces to keep the majority of children safe. There needs to be public health guidance that keeps the majority of children safe so that families have input that they can look to and have a shared decision with their primary care provider. But when there is no public health guidance, it's extremely confusing and overwhelming for families of young children who already have so much on their plate.
Well,
Could New Hampshire DHHS provide that guidance without the vaccine mandate being in the law?
That's a great question. Thank you. I can't tell you how many times I have parents say to me, well, you know, which vaccines are required by the schools? Those are the ones we'll get. Because they assume that the people making the decisions have their best interest and their child's best interest in mind, and that if the vaccine was really preventing a serious disease, it would be one of the required ones. And so if we take a vaccine off of that school immunization requirement, it signals to families that it's not really that important.
Representative Kesselring.
Thank you, Mr. Chair, and thank you for taking my question. So you mentioned a little bit of the confusion that goes on now in your patients and all that. Could you elaborate on what you think the issue is with that now, because we currently have this in the law?
So the confusion is that people are reading the news and they see that the federal Secretary of Health changed the rules about the vaccinations, and so they wonder, as Representative McLean pointed out, they wonder, oh, there must be some reason. Like, did we find out that there's some, you know, big difference or a change? And we did not. There's no new information. It's just a change of opinion. That, yeah, I hope that answers your question.
Representative Palazzo.
Thank you, Mr. Chair, and thank you for taking my question. So you focused in your testimonies on changes on federal level, but we just heard about changes in New Hampshire where your organization was instrumental to bring back recommendation for toxic and ineffective COVID vaccine. So I'm not sure how can we recommend another adult disease and ignore all the side effects.
Thank you. I don't think this hearing has anything to do with the COVID vaccination. I think it's about the hepatitis B vaccination, as I understand.
Okay, anyone else? Seeing none, thank you.
Okay.
No one else has signed up to testify on HB 1719 FN, so I am going to close the public hearing on this bill and open the public hearing on HB 1784 FN, and thank you to those who are coming forth to testify for your patience. Now we do need a pink card represent. Oh, here it comes. Okay, I'm going to be turning the gavel over to the Vice Chairman Mazur at this time and stepping out, but we'll continue. So thank you.
I'm going to try and time these. Sarah's going to hate me. All right, we're going to start the hearing. So if we can take our conversations out into the hallway. Yeah. It's not mine. All right. As our chair mentioned, we are opening the hearing for HB 1784FN, sponsored by Representative Miles. You are free to tell us about your bill.
Thank you, Madam Vice Chair. This will be much less time-consuming and less controversial, I promise. For the record, my name is Representative Julie Miles, Hillsborough District 12 from the town of Merrimack. I'm a nurse, nurse leader, educator, house supervisor, and I work in the field of clinical data, research, and health insurance. I'm the prime sponsor of House Bill 1784, and I appreciate the opportunity to speak with you today about this bill. The work of the Healthcare Consumer Protection Advisory Commission and the shared responsibility we have to ensure that this trust fund delivers meaningful benefit to New Hampshire patients. My central mission, both professionally and legislatively, is to improve access to care where it is diminished in the wake of hospital mergers and to steward trust fund monies in a way that achieves maximum impact for the greatest number of patients. I currently serve on the Healthcare Consumer Protection Advisory Commission, chaired by the Attorney General, and the Commission's mission is clear and critically important: to help New Hampshire residents, particularly those affected in merger-affected communities, gain, preserve, and restore access to healthcare services. House Bill 1784 was brought forward in good faith to strengthen that mission. My concern is that the current statute may leave room to ensure the trust fund expenditures are tightly aligned with direct patient impact, measurable outcomes, and timely benefit. At a time when communities are losing services, providers are stretched thin, and patients are waiting longer or traveling further for care, every dollar must work harder. At the same time, the intent behind RSA 7-6-G is to give the Commission flexibility to respond quickly to unforeseen service gaps following healthcare consolidation. A recent example involving the amount of trust fund dollars was used for the town of Plastow when they lost their advanced life support services following an Exeter hospital acquisition. And that demonstrates exactly why the flexibility matters. The ability of the HPAC to act swiftly ensures that critical emergency services were not lost to a large part of the Seacoast. That makes it clear that nimbleness and responsiveness are imperative. It also is clear that this bill, as introduced, raises legitimate concerns regarding constitutional checks and balances, administrative burden, and unintended delay. Those concerns deserve careful consideration. For that reason, Madam Vice Chair, I believe the most responsible course of action at this time is not to advance House Bill 1784 as written, but also to not abandon this important policy question. I respectfully request that the committee hold House Bill 1784 without action in exec session to allow the full Healthcare Consumer Advisory Commission to formally evaluate the bill, consider its potential impacts, and provide comprehensive input to the legislature. My goal is collaboration, and any statutory changes affecting this fund must be constitutionally sound, operationally realistic, and firmly centered on patient access and outcomes while preserving the ability to respond rapidly when communities are at risk. I remain committed to working with the Attorney General, the Commission, and the Committee to ensure the Healthcare Consumer Protection Trust Fund continues to fulfill its purpose, getting healthcare to people and patients both now and in the future. Thank you for your time and consideration. I respectfully ask the committee to hold House Bill 1784 without action so we can continue this thoughtful and collaborative work.
Thank you. Any questions? Representative LaMontagne.
Thank you, Madam Vice Chair. And thanks for taking my question. I wasn't really familiar with this trust fund before, but I'm curious, were there any particular grants to state agencies that you had a problem with? I'm wondering why state agencies specifically are excluded.
Thank you for your question. And that's exactly the type of thing we'd like to talk further about with the full commission. We want to make sure that we have specific guidelines in place to, again, to reiterate, to just make sure that the money is going directly to things that affect direct patient outcomes.
Thank you. Representative Weber.
Thank you. And I don't have the deadline for this bill because the House web stuff seems to have seized up. But Is the commission going to be meeting in a timely fashion so that you can give us feedback before the deadline? I'm seeing heads nodding behind you.
Yes.
I was going to say, or would we have to keep it for an interim study? But
we do have scheduled meetings coming up, and interim study may perhaps be the avenue we take.
Okay, thank you very much. Appreciate it.
Thank you. Representative McLean, did you have?
Representative Weber has a crystal ball and asked my question.
Thank you.
Thank you. Any further questions? All right, we'll move on to the next. Senator Tim McHugh. Welcome, Senator.
Thank you. It's always good to be back in House HHS. Matters near and dear to my heart. I'm Senator Tim McHugh. I represent District 11, which is Merrimack, Milford, Amherst, and Wilton. And I'm in my third year as Vice Chair of the Healthcare Consumer Protection Advisory Commission. This incredibly valuable commission was created by the AG to address unforeseen matters as a result of healthcare mergers. CMC was in the news. Everybody knows about that one. The first was in Rochester, Frisbee, where HCA took over there. There's been several others. Exeter, Beth Israel Lahey took over Exeter. There was a couple in the North Country. So what happens during these mergers, as part of the approval process, there's a settlement decree and stipulation to set aside some money for things that we could not have anticipated during the merger process. And the AG has done a fantastic job creating this commission and this trust fund to address those types of issues. The commission has pushed our hearings out into those communities to ask community members to tell us their healthcare story, pre and post merger, so we can find out specifically where this money needs to go, and it's their money. I mean, it's money that comes from the acquiring entity, but let's face it, that money gets passed on into the healthcare cost. It's the cost of doing business, so it's really the community's money. So I'll give you a couple of examples of things that have come as ideas, not all as formal proposals, but questions and answers during some of our presentations. In one case, there was some dental clinic services being provided in K-5 or K-8 schools by local dentists, oral exams and things like that. And those were completely underwritten by the prior owner of that hospital. And after the merger, the merging entity, the acquiring entity, called that dental clinic and just said, we're not going to pay that $80,000 a year anymore. And for 20 years, they had had these oral health screenings in the schools, and then they were suddenly cut off. That's a perfect example of where this trust fund money, small dollars, $80,000, out of an anticipated about $20 million over 10 years, the money comes in slowly. It's a perfect example where this money can be spent to replace a service that went away as a result of a merger. And there's lots of examples like that. The first settlement decree or stipulation settlement called specifically for an academic study. So the commission was bound and required to award an amount, and it turned out it went out to bid. I think there were 2, maybe 3 bidders, and the award went to UNH to fund a 4-year, about 1.38, I think, or about 1.3 something million dollar study that will take 4 years, and hopefully will demonstrate and provide some data that is actionable. My concern as a med device CEO and a 30-year medic and a guy with a bunch of innovative medical device patents is, will that study drive improved patient outcomes? Because we have thousands of patients right now craving access and craving improved outcomes. So I tend to favor things that make an immediate difference. So 4 years, 1.3 million academic study when we have lots of internal resources. We have incredibly talented actuaries and data scientists and PhDs within DHHS and DOI, and we heard this testimony. That was some of the reason for the language in the bill. Now, back to the bill. It's very much I'll wrap up. I have 1 o'clock as well at the State House, so believe me, I'll wrap up quickly.
Thank you.
The reason that the bill was put in was as essentially a placeholder. So you could consider it literally a placeholder. And we want to have the full commission have input on this. Since the bill was published, we've had a new chairman and 2 new public members. So lots of changes happened. We have a meeting scheduled for 1/26, so 2 weeks from now, or yesterday, and then meetings in February, March, April, and other meetings out in the communities. So lots of activity. It regularly meets. So we will provide you that input, and we'd appreciate it if you look favorably on perhaps doing something. But the answer might be the commission, the commission, majority of the commission says we're all set right now. But we wanted to have something in place. So I'll take questions or not.
I actually have a question.
Sure. Thank you.
So the prime sponsor, Representative Miles, asked us not to take action. Can you clarify what that might mean?
So in my opinion, I won't speak for the prime sponsor, but in my opinion, it would be prudent to wait. I don't know what the deadline is either. I don't think it's an early bill, but even if it is, we have at least 1 or 2 meetings of the commission prior to that, and I'll commit, and I'm sure the prime sponsor, I'm guessing, would as well, to get feedback to the chair and the committee prior and make some amendment recommendation or perhaps a recommendation for interim study, if that's all right with the chair.
Okay. Thank you very much.
Question.
Any further questions?
We want to be collaborative and have the whole commission have input, and the bill was just published, so.
Okay, Representative Weber.
So basically what you're asking us to do is make sure that our chairman doesn't schedule it for executive session until after you have had to take time to take further action and get further information to the committee. Is that correct?
Yes, please. And thank you, Representative Weber. If there's a subcommittee process in this committee, that'd be great. It'd be a great place for it. I don't know how often you guys do subcommittees here, so.
Thank you.
Thank you so much. I appreciate it.
Any further questions? Thank you very much.
And Madam Chair, could I just make a point of order for the committee?
Yes.
Just for everybody's information, because nobody has intended any impoliteness, but whoever is in the chair is the chair. They're not the vice chair anymore. So whoever is presiding, just as the speaker is the speaker, whoever's in the big chair is the chair.
Thank you. I wasn't going to say anything, so I'm glad you did. All right. Thank you, Representative Weber. All right. On to our next person here to testify, Brandon Garrett, representing the Attorney General. You indicated 5 minutes. If you could keep it to 3, that would be appreciated, as we are very behind schedule today.
I will do my absolute best.
Thank you.
Good afternoon, Madam Chairperson. My name is Brandon Garrett. I am a Senior Assistant Attorney General, as well as the Chief of the Consumer Protection and Antitrust Bureau at the Department of Justice. I am not a sitting member on the Healthcare Commission. The Attorney General fills that seat. I was intimately involved in the negotiations of all of the merger resolutions that resulted in this commission and the funding that we're talking about. I also am intimately involved in attending the commissions and participating in those discussions. The Attorney General objects to the proposal because it's unnecessary at this time. The language that currently exists in the statute was very carefully crafted, intentionally to provide this commission, put this commission in the best possible position to accomplish its goal, which is, in the event that we identify problems with a potential healthcare merger and elect not to move to block that merger, because doing so potentially has significant adverse consequences, such as the closure of a hospital in an area that may not have another hospital. How else can we resolve unforeseen consequences on the other side of that merger? And the Attorney General decided that money, the ability to go into communities and actually address situations as they arise, and the flexibility to identify those situations as they come up, that was an option that the state was lacking, and this provides that opportunity. So the language is broad, it's intentionally broad, there's appropriate oversight, it requires the Attorney General to get approval not only from the Commission, but also from the Governor and the Executive Council before any dollars are expended from this fund. And the proposed recommendations in the current legislation are just not necessary and would actually inhibit the Commission from fulfilling its mission, as it would not be able to act swiftly. It would also cost a significant amount of money to staff the type of analysis that would be needed in order to meaningfully assess future grants with some of the criteria that's contained in the bill. So I think I managed to do that in under 3 minutes. I'm happy to take any questions.
You still have a minute, actually, but I won't give it to you.
Happy to take any questions.
Okay, thank you. Yes, Representative Palmer.
This is a sort of tangential question, but I'm on the board at Valley Regional. Is the money that when Dartmouth had to put forward, is that in this pot?
It is.
Okay, that just makes it easy.
Thank you, Representative Polizov.
Thank you, Madam Chair, and thank you for taking my question. Can you give some historical background since when AG became involved in merger negotiations and what guides your involvement? Is it some legislation that directs you to be involved? Thank you.
Sure, I'd be happy to respond to that. So there's actually two functions of the Attorney General's office that are involved anytime there is a proposed affiliation between two healthcare institutions in New Hampshire, one of which comes through the Director of Charitable Trusts. That is not my role. That analysis looks specifically at whether due diligence was put forth to make sure that the transaction is in the best interest of the community. That's a statutory role. It's created in the Director of Charitable Trusts, the statute that establishes that unit and its responsibilities. My bureau, the Consumer Protection and Antitrust Bureau, we have statutory authority to enforce the state's consumer protection and antitrust laws. State antitrust laws specifically make it unlawful for a merger, makes a merger unlawful under a number of circumstances, one of which is if it would restrict competition in a designated service area because the two merging entities compete in that service area, and that loss of competition as a result of the combination is likely to result in a substantial loss of competition after the merger, which has the potential and realistic potential to result in significantly higher prices for consumers, as well as a loss of consumer choice. So anytime there is a proposed merger, the Consumer Protection and Antitrust Bureau does a very lengthy and in-depth comprehensive review for potential violation of state and federal antitrust laws. Those reviews are confidential. The public never gets to hear about them unless we choose to litigate the case. That's by statute. The study that was mentioned by the senator, it's more than just a study. This was the primary focus of why we chose to proceed with establishing this commission. It's essentially trying to create a gap, fill in a gap in the state, which is some sort of a health policy institute that takes a high-level look at what is the actual impact on consumers of healthcare consolidation. This state doesn't have that. All the state has is an antitrust bureau that can do an investigation and do one of two things. They can resolve it, or they can litigate to block the merger, which, as I talked about earlier, sometimes is appropriate, sometimes is not. So the idea behind the UNH study is to actually do what we can't do and look at the history of healthcare consolidation in the state of New Hampshire and the current landscape of who owns what systems, where they're located, and what that impact actually has done to things like prices, consumer choice, and quality of care, and make that information available to the public so that there's more transparency there, because right now there's insufficient transparency. So that was part of the reason why that specific proposal was a mandate of the original settlement that set up this commission.
Thank you. Follow up? Yep.
Thank you, Madam Chair, and thank you for taking my follow-up. You already started answering, but could you a little bit tell me, like, if our antitrust laws in this consumer protection sphere are guided by federal laws, and if you know what other states are doing in similar circumstances?
So did you was part of the question whether they're guided by federal laws? Yes. So our Consumer Protection Act, which is RSA 358A, and our antitrust statute, which is RSA 356, are both modeled after similar federal laws that are administered by the FTC that also take parallel looks at mergers and competition, things like that. In terms of what other states are doing, it's vastly different depending on what state you're talking about and how well resourced that Attorney General's office is and what the impact of the individual merger at issue is. You have had several states in the country that have identified significant anti-competitive results of proposed affiliations and have filed lawsuits to move to block that consolidation from happening. You also have states on the other end of the spectrum that may have like a single lawyer working in their antitrust bureau and doesn't realistically have the ability to do that robust type of litigation, or may feel that they don't need to because you don't have the similar impact on competition based on the review. So states are all over the map. Every state is very different. New Hampshire's healthcare market is very small and very consolidated. So comparing us to one of the states I referenced is Pennsylvania. Like they have been active recently in blocking a merger. Our state is very different than Pennsylvania, so both size-wise and the healthcare landscape-wise.
Thank you. Any further questions? Representative Woods.
Thank you, Madam Chair. Just for clarification, we're going to be getting new information, and we're sort of been asked to hold until that further information is forthcoming. And I think, if I understand it correctly, and my question is the Attorney General's office a part of that process, or just after that process is complete, reviewing it? I mean, this is going to be really critical, I think, in terms of the information we get during the next round.
For this specific bill. So the Attorney General is currently the chair of the Healthcare Consumer Protection Advisory Commission. The Attorney General's position is that no changes are needed to the statute at this time, but has agreed to participate in good faith in discussions and consideration about whether different changes may be appropriate. The proposed changes in this bill, the Attorney General feels, are just not necessary at this time.
Thank you. Any further questions? All right. Thank you very much for your testimony.
Thank you.
Right. Lastly, we have Lucy Hodder from the UNH law professor. And you have indicated 3 to 5 minutes. If you could keep it to 3, that would be appreciated.
Absolutely.
Thank you.
Thank you, Madam Chair and members of the committee. Really appreciate the opportunity to be here. I'm Lucy Hodder. I direct the health law program at UNH Franklin Pierce School of Law, and have practiced here in healthcare for about 35 years. Married to a physician, had my kids here, et cetera, et cetera. I want to first let you know that I'm here because this trust fund and the commission is critically important to healthcare consumers. I want all of you to think how you would describe our healthcare system or your efforts to navigate it. We have wonderful players. We have an incredible system, and we are trying to make sure this commission is that consumers have the information and the resources they need to help navigate our future in New Hampshire. I just want to call out Representative Miles, who is a member of the commission. Big, wonderful impact. She is a longstanding nurse and brings a lot to this conversation. And I really agree with her commitment to making sure this commission is nimble, responsible, and really stands in to answer the questions of the consumer in a very complicated world. We've had mergers, transactions. I think every one of us has experienced the changes, and the AG's office actually negotiated this original trust fund and commission in the context of the mergers. So at this point, I completely agree, legislation is premature. The commission needs to spend some time working itself out. They did just not renew 2 very experienced people who were members of the public who were on the commission, 2 people who have more healthcare experience than probably all of us combined, except for maybe Representative Miles. And so there are new public members coming on to the commission. It is critical that this commission be able to respond to the needs of the consumers and access information. So really disagree with the efforts of this legislation to limit what the commission's information might be, how it gets information, and how it helps consumers navigate the changes going on in New Hampshire. So I'm going to end with that unless there are any questions. Really appreciate the opportunity to come before you and respect the members of the commission that were here today speaking about its import.
Thank you. Yes, Representative Polozov.
Thank you, Madam Chair, and thank you for taking my question. Previous speaker indicated that some states don't do such a thorough antitrust investigations. New Hampshire does for healthcare mergers. What kind of negative effects do you see in those states who lack this mechanism?
So there are a couple. That's a great question, and I think your questions have really gone to what exists now to help make sure consumers are protected or continue to have access to the care they need or understand the changing environment. Healthcare is incredibly complicated. It's also very well funded. We have very large entities coming and going in New Hampshire. We have venture capital moving into the state. We have a lot of shifts in the delivery of care. We have community providers struggling to survive. In other states, there is usually a much more robust effort to collect information and make decisions based on evidence. Our Attorney General has done an incredible job to try, with the resources it has, to manage overseeing consolidations, where oftentimes the entity coming to take over a hospital in New Hampshire is, a multi-billion-dollar international entity. And so the AG is trying to figure out how is that going to impact New Hampshire. And this fund is there to help make sure consumers understand that as well. Other states have done some of them have done good jobs, some of them haven't. Most of them have more focus on the future of their healthcare delivery system than New Hampshire has been able to have.
Follow up? Yes.
Follow up. Maybe I missed it from previous testimonies, but I'm new to the system, so excuse my ignorance. So what happens if the service is discontinued and the fund has money to cover that need? People referred to some different medical facility. How exactly should it work, and how does it work?
I'm not sure I completely understand the question. If the AG didn't review the transactions, is that your question, or if the commission didn't exist at all?
No, more like how those funds help people. So if service is discontinued after merger, so does it mean they need additional money to receive that service elsewhere and they get it, or how exactly does it work?
That's a great question, and I think the AG could probably answer that better. Oftentimes when the mergers take very many different forms, and oftentimes a merger, a transaction happens in order to save a hospital that's suffering, and therefore a lot of services are cut after. Oftentimes the community doesn't know they're cut. Sometimes it's the responsibility of the new parent company to maintain those services, and the AG has put some conditions on the mergers to make sure certain services continue, but oftentimes they don't. And I think looking at our total, where our services are provided, when they're discontinued, what has been discontinued, and why is a really important part of the Commission's work. Is the Commission the entity responsible for meeting the needs of those services? I think that's what it's going to talk about going forward as to exactly what its responsibilities are.
Thank you. Representative Weber.
Thank you, Madam Chairman, and thank you and welcome back. It's that's partially answered my question, because the first part of my question was, so as currently constituted, the Commission has a whole bunch of different things that it's charged with doing, one of which is communicating with consumers about what's going on and what the effects might be, and another is determining best uses for this particular fund that's been set up. Is that right?
Yes, the primary purpose of the Commission is to be advisory to the Attorney General on the allocations and use of the trust fund that the Attorney General has set up based on agreements with several hospitals that were court approved.
Okay.
So again, the fundamental purpose of the trust fund is really set forth in court approved agreements with the merging entities, and the Commission is advisory in recommendations about how to make sure it's used in the best interest of the consumer, both to provide information, to figure out the impact, to set policy going forward, and to make sure consumers are well represented in the process.
And just my final one, and maybe it was said and I missed it. How long has the Commission been in existence?
I think it was first funded in the agreement that was court approved in the transaction where Beth Israel Lahey took over Exeter Hospital, and then there have been two transactions that have resulted in funding when Dartmouth Health completed its affiliation with Valley Regional, and then when HCA, multinational corporation, took over Catholic Medical Center.
Gotcha.
Which I want to just tag on that. You know, you asked about federal law. What we're seeing now is oftentimes if there is a transaction where the hospital is actually paying a purchase price, so a for-profit takes over a not-for-profit, we've seen they're starting to set the purchase price at an amount that's below the federal antitrust review, so there is no federal review for those transactions.
Thank you. Thank you. That's very helpful.
Any further questions? Thank you very much for
Thank
coming
you so
today.
much.
All right, I see no more pink cards for this bill. Is there anyone out there that would like to testify? All right, I'm going to close the hearing for HB 1784 FN and move on to HB 1798 FN. Prime sponsor is Representative Sorensen. I have no pink cards at all on this bill. So if we could start sending those forward, that would be great.
On the black.
Is it Jerry Sorensen? Is Representative Sorensen here? Oh. Okay. Is your first name Carrie?
Carrie.
Okay. Thank you.
Just one right in that it's wrapped.
Yeah.
This is representative. When you fill in a pink card, make sure you make it clear that you're a representative and what district you represent.
Oh, sorry about that.
That's okay. Thank you
I'm
very
about
much.
to say that.
All right.
This way we have it written down.
Here we go. Okay. Please tell us about your bill.
Thank you so much, Madam Chairman. For the record, I'm Representative Carrie Sorensen, representing Rockingham 28, Portsmouth. I'm pleased to introduce House Bill 1798, which will help keep children in low-income families healthier. This bill will direct DHHS to apply for a waiver to cover 100 diapers a month for the first year of a child's life. So far, 2 states, Delaware and Tennessee, have these waivers. This bill's more modeled off of Tennessee's. So diapers are really expensive, we know that. For the first few months, families go through a lot of them. I can personally attest to this. You all heard my baby in the house last year. As you know, SNAP does not cover diapers. That means low-income parents have to make more difficult choices of whether they spend their money on diapers or whether they spend money on food or their heat or their rent. Or do they ration diapers, risking their kids' skin and health? Neither choice is acceptable for a child's well-being. If parents do choose to ration diapers, their child is more likely to get UTIs or other illnesses, and parents may have to miss work. That's bad for both the family's financial health and the productivity of our businesses. While this isn't the Finance Committee, and I know this isn't a budget year, I hope that when we're looking at this bill, we can take into consideration the policy behind the bill, not just the financial constraint. I could go into all the details about that, but I know you guys are time consumed, and so I will answer questions on that if you have questions. But basically, there would be an appropriation that would help cover the cost, and it's based on the number of Medicaid births, so more on the mother's Medicaids, not the babies with Medicaid, so it would be hopefully less expensive than if it were done based on the babies with Medicaid. There would also be a federal match. I tried to give the department enough time to put together the waiver so that CMS could approve it, and the department would be reporting along the way to an oversight from HHS. Excuse me. I would like to add that I'm also very proud to have bipartisan support from on this bill, thinking that hopefully we can look at it as a supporting our babies and our moms approach. Thank you so much, and I'm happy to answer any questions.
Thank you. Yes, Representative Palmer.
Thank you, Madam Chair, and thank you for taking my question. So I'm curious, you mentioned Tennessee and Maryland?
Delaware.
Delaware.
Yep.
Sorry. Well, I'm curious if other states have come up with other ways. I was talking to my daughter last night who has an infant, who would have been crying had she been, well, anyway. And she just moved up from New York this past year. And they have a program through the WIC program. And so I'm just wondering if you looked at other models or whether there's more information that might help figure this out.
Of what the best approach is?
Yeah, aside from this.
Aside from Medicaid? You mean?
To be honest, I'm not sure whether I think the WIC is, it could be a New York State thing, but I'm pretty sure from what she said that it's somehow a Medicaid thing as well, but I'm not sure.
Gotcha. So I'm not an expert on all of these things. I think one of my co-sponsors had written a thing which covers what SNAP versus WIC covers. WIC does cover baby food and formula, which is slightly more in the category of diapers. SNAP does not, to my knowledge, cover anything that is not food, right? So I think if we were to go another route, it would have to be WIC versus SNAP. And I don't know of other states specifically, I can get back to you on that have the WIC inclusion for diapers. I do know that there was a program, is currently a program in Stratford County that, and Devin is going to talk a little more about this, but they had a very successful diaper program that got federal funds that's doing well. However, their program, it's a pilot program, they're ending in September. So she talks a little bit more about that. Hopefully that answered your question.
Thank you. Who was Representative Polozov? I saw your hand first.
Thank you, Madam Chair, and thank you for taking my question. Do you have any information on existing venues that a woman can get diapers for her child? I know sometimes there are like a few diapers from hospital, a few diapers maybe from pediatrician. Are there any I don't know, charitable organizations that help women in need?
Of course, yeah. So there are a few programs. One of them is the Manchester Diaper Pantry, and they are a charitable organization that is run through donations. And I believe their director is going to be here today to testify as well. Her name's Tia. But they are in Manchester. They help support moms and babies, but they still can't meet the demand that there is. And then there is more nationally a national diaper bank, which helps organize all of the smaller, more local ones. We're not necessarily directly involved in the national diaper bank. When you go on their website, it says that we are not at all participating in the state, to my knowledge. And my understanding is that even though there are some charitable organizations that need still just the supply still can't meet the demand.
Thank you. Representative McGrath.
Thank you, Ms. Chair, and thank you for taking my question. So, do you know, and this might be what you just said, you're not sure, how Maryland and Delaware, what the process is? Does it go through the doctor's office, the pharmacy, the grocery store, and how they bill Medicaid?
I know for Tennessee, it is at the pharmacy. You have to go and just use your Medicaid card. You do not need a doctor's referral. And the diapers are just sent in varying sizes. And currently it's a new program. They were both started last year, so they're still getting up to speed with them. But currently they have like 3 different brands and some sizes where you can go and get them, and more brands and sizes are being added. As far as the billing piece of Medicaid, I do not know that part, but I can try to find that out and get back to you.
So follow up, is that what you foresee for New Hampshire? Is it going through the pharmacy?
I think I'd be open to that because that seems pretty easy because there are pharmacies near lots of people and it doesn't require any additional like state funding or additional people to do it because the diapers can just be out in the diaper aisle, right? And that.
Representative Lamontagne.
Thank you, Madam Chair, and thank you for taking my question. I'm familiar with the program in Stratford County that's run through Community Action Partnership of Stratford County, and it has been very successful. Families are very appreciative of the diapers and the cost savings. But as I understand it, this bill will direct Health and Human Services to submit a waiver, but they could come up with the distribution plan that makes the most sense.
Of course.
Is that right? And as a former WIC nutritionist and director in North Carolina, WIC seems like it would be an excellent venue for that. So that's more of a comment, I guess. But what do you have a vision of how you think it would be implemented in WIC clinics, or how could we best pass the savings on by perhaps bulk buying and distributing them directly as opposed to the participants paying retail prices?
That is a very good question. I would love to get back to you on that with a little more research on my part. First, the bulk buying. I have never bought anything bulk in the way that the like diaper pantries and things have. So I'd like to get back to you on that one if that's possible.
Thank you. Representative Lucas.
Need to turn the mic on.
To your knowledge, do any of these programs provide a diaper service, or is it limited to disposables?
Between Tennessee and Delaware, I believe they are just for disposables, and I considered doing it with reusable diapers, but that becomes complicated if families have to use laundromats, right? So I decided against doing that one.
Thank you.
Thank you. Representative Polozov.
Thank you, Madam Chair, and thank you for taking my other question. So, if one of the stated goals of this bill is to avoid things like urinary infection for babies of mothers who try to ration diapers, are you aware of any statistics for New Hampshire where such cases were observed?
Of like how many babies get infections and things like that. I'm not aware of the particular amount of infections, particularly in New Hampshire. I do know that in the New England Journal of Medicine a few months ago, they did have a report from, this is not in New Hampshire, but in Syracuse, New York, where a pediatrician's office handed out diapers to their families in a similar such manner, and they had a drastic decrease. I can't remember the exact numbers, but I can look that up and get it back to you if you would like.
Okay.
Sure.
Thank you. Any further questions for the representative? Thank you very much.
I didn't fill out a card for her because I didn't know how it works, but I had a colleague who was going to testify. Her testimony ran late, and I would like to just pass out her testimony, if that's okay.
That's fine.
Okay. And just highlight one thing. She talked about, this was Representative Leanne Kluger from Nashua. She talks about the high cost of diapers in the testimony. You'll read it, and she said it's about $1,200 a year. And honestly, I think it was kind of low, but that's just my perception of it based on me buying diapers for one child. But I'll pass that out.
Okay, thank you.
You have yours as well?
Yeah, I gave it to you. That was Carrie Sorensen. Okay.
And the other, no, her testimony.
Madam Chair, if the other representative isn't testifying, we don't need a pink card because they weren't here in person.
Yeah, no.
But if you have written testimony, then the clerk can keep a copy of that and it becomes part of the record.
Yeah. Yep. Thank you. All right. Next we have Executive Counselor Karen Leott Hill. Thank you. If you could keep your testimony to 3 minutes, that would be appreciated.
Great, thank you. Good afternoon, members of Health and Human Services Committee. Thank you very much for having me. I'm Karen Leo Hill, Executive Counselor for District 2, representing 81 cities and towns in the western part of New Hampshire. I'm here to support HB 1798, which I think is a modest, thoughtful proposal that would allow New Hampshire to seek federal approval to cover diapers for infants during their first year of life under Medicaid. Anyone who's raised a child knows that diapers are not optional. They are a basic health necessity. For families already struggling to make ends meet, diaper costs can create real hardship, and I would agree that $1,200 is, I think, on the low side of the actual cost, leading to unsafe substitutions or delaying medical care. This bill focuses narrowly on the first year of life, when infants are most vulnerable, and uses a demonstration waiver so the state can proceed carefully and responsibly. HB 1798 reflects the kind of smart preventative policy New Hampshire should embrace. By supporting infant health and family stability early, we can reduce downstream costs associated with emergency care, infections, and parental stress that interferes with work and caregiving. The bill is limited in scope, includes reporting requirements, and makes a small appropriation to leverage federal partnership rather than creating a broad new entitlement. This is a common sense investment in healthy starts for children, stronger families, and better long-term outcomes. For those reasons, I urge you to vote ought to pass on HB 1798. Thank you.
Thank you. Are there any questions? Yes, Representative McGrath.
So just to clarify, the money for the diapers would be coming from the federal government and not the state?
I am not the bill author, so I don't know the specifics, but as I understand it, these dollars oftentimes, so in our Health and Human Services budget, many of the dollars that the state spends are able to leverage federal dollars. So I don't know if that's a possibility specifically on this bill, but I would defer to the bill author on it. In general, I do think that, what is the expression? An ounce of prevention is worth a pound of cure, and I think that diapers for infants to help put a little bit of stress off of moms who are facing tough circumstances could really be an ounce of prevention.
Thank you. You have a follow-up? Yes.
I just think that's important information. Can we ask the prime sponsor?
You can't do it again.
Yeah.
They can send it into the committee.
Yeah. Was it part of your testimony that you passed around? Was that information in there? Okay. I think we can request that information be emailed to us. So if you could do that, that would be appreciated.
So thank you for confirming that.
Yeah.
There are federal funds that would be leveraged through this bill.
Representative Gopal, you have a question?
I'll phrase it as a question. Is it true that most Medicaid is roughly a 50% match? So the state kicks in 50% and the federal government kicks in another 50%?
I am not the commissioner of HHS, but I know that there are different categories of Medicaid that are able to draw down at different rates. So I don't know if the average might be around 50%. Sometimes it's more than that. Sometimes it's less than that. I know that, for example, Medicaid expansion, I think, was a 90-10 match. So I know the rates vary somewhat, but there is typically a match of some sort depending on the, conditions.
Thank you. Any further questions? Yes, Representative.
written testimony?
I do not. I apologize. But I would be happy to submit a letter. I will do that. Great. Thank you so much.
And also, Karen.
Yes.
Yeah, she sent hers around, I think. Representative Sorensen, did you pass around you? Okay, you could email that. That would be great. Thank you. Okay. All right. Next person to testify we have is David Chorney. Did I say that right? Okay. From Medicaid DHHS. Thank you. If you could keep your testimony to 3 minutes.
Happy to. David Chorney, I'm the state's Deputy Medicaid Director, and here to just provide any information or answer any questions the committee has. And I'm happy to start with the question about matching funds. So all Medicaid covered services do get federal matching funds. It depends on the category of eligibility the individual who's getting the services in. In this instance, for children, it would be largely a 65% federal match. So it would be 35% general funds, 65% federal funds. There's a small subset of children's Medicaid that only gets a 50% match, but it's limited to children who have other insurance, which is a small portion of the covered population. It's about 1,500 children right now. And so we had estimated that for state fiscal year 27, the general fund expenditure would be approximately $165,000, and we'd anticipate receiving approximately $178,000 in federal funds, matching funds, and then assuming CMS approval and implementation in state fiscal year 28, it would be $900,000 in general funds and just over $1 million in federal matching funds.
Thank you. Does that end your testimony? Okay.
Yep.
Are there any questions? Yes, Representative McGrath.
Just to clarify, you said in 2027, 165 would be the state amount,
That's correct.
and we would get 178 match from the federal.
That's correct. And most of that would be the cost to complete the 1115 waiver request, which is, and 1115 is the way in which we would get CMS approval to expand coverage for the diapers for children under 1.
Thank you. Thank you. Any further questions? Do you have any written testimony?
No.
No? Okay, that's fine. Oh, Representative Kofalt.
So just to be clear, the numbers you're giving would be, it's not, the federal matching funds are not offsetting the state amounts. They would be so in other words, for, I think you mentioned, I think it was implementation costs, you were saying $900,000 from the state and $1 million from the feds. So for a total of 1.9, not a net cost of 0 to the states.
That's correct.
Okay,
Yeah.
thank you.
Thank you. Any further questions? Seeing none, thank you very much. Okay, Christine Arsnow. Oh, she had to leave? Okay. All right, then Devin Quinn.
Madam Chair, could you just tell us whether the person who isn't still here is supported or opposed?
She's supported.
Thank you.
Yep. And I don't. She wasn't here, I guess. And Ms. Quinn, if you could keep your testimony to 3 minutes.
I will.
Thank you.
Hi, my name is Devin Quinn from the New Hampshire Women's Foundation. We are a community grant-making organization, statewide grant-making organization, and so we hear about the need for diapers a lot, and that is why we're really excited about this bill. It supports moms, and so we're passing around a couple of folks who wanted to be here to testify but can't. That includes Dr. Arsnow, who just left. Her testimony, you heard about Stratford County CAP, their testimony. You heard from about Tia Middleton, who runs the Manchester Diaper Pantry, her testimony, as well as testimony from the Nashua Soup Kitchen. So I'm trying to include everyone's testimony in 3 minutes, and also I think I can answer a lot of the questions that came about, and I would really love to get to all those too. So let me just start with highlighting a few things. First, I want to talk about the Stratford County CAP has this pilot diaper program, and this is the first thing that you're being passed around. It's a fantastic program. They are leveraging federal dollars and distributing diapers across the state in a lot of different places. It's very successful, and it's ending this September. And so we know that there's a huge need for these diapers. And you might be asking why we're asking for this in a non-budget year, but it's because these dollars are ending at the end of this year. And so we want to get this conversation started to make sure that there's no gap in what families really need. We know that the cost of living is huge in New Hampshire, inflation is high, and if we wanted to target a little bit to a specific group, wouldn't it be moms with under 1-year-old babies for diapers? This would be a really helpful way to help moms make ends meet. So they say, Stratford County CAP says that parents consistently tell them that reliable access to diapers reduces stress, prevents missed childcare and school days, because you can't drop your kids off unless you have diapers for that day. If you can't get your kid to childcare, you can't go to work. It improves hygiene and health outcomes and allows caregivers to remain engaged at work, in work and training. And you'll also see in their client testimony in here that someone says, thanks so much for doing this. With inflation going up, it's a huge help to not have to worry about diapers. Someone talks about how they have been able to save hundreds of dollars a month, helps especially during the off seasons for both my fiance's job as a substitute for Head Start, and he does line striping and seal coating. Dr. Arsenault, she is a pediatrician and president of the New Hampshire Center for American Academy of Pediatrics New Hampshire chapter. She's supportive of this, and she says that covering diapers supports healthy child development and may reduce downstream healthcare costs by preventing avoidable complications and medical visits. June Lehman from the Nashua Soup Kitchen says that they can get clients about 30 diapers a week. I'm sorry, yeah. I would love to answer the questions about distribution. Could I respond to some of the questions that I think might be helpful?
Well, I'll have them re-ask their questions.
Okay, sorry about that, yeah.
Okay, no worries. All right, Representative McGrath.
Yes, what is the plan for distribution?
Thank you so much for taking that question. So I believe Representative Sorensen wrote this bill to be flexible to Medicaid to write this waiver, and so that it could be amenable to be as low cost as possible. The two other programs, Delaware and Tennessee, one of them offers 80 diapers a week. This one's 100 a month. One of them offers up on children's insurance up to 2 years, but I think Representative Sorensen's intention is for it to be on the mother's Medicaid, which would, at a lower qualifying income, would be a lot fewer. So that her, the dollars she's thinking are based on births on Medicaid moms, not on Medicaid children, which would be more. So we're trying to find a nice way to make this as affordable as possible while doing some outreach, but maybe not at the level of Tennessee or Delaware. For distribution, also keeping in mind that cost. So yes, there are, like CAP works with lots of different organizations that meet the folks all over the community. And yes, WIC is a great place to reach folks like that. But we wouldn't want to have it through the WIC. You could do it at the WIC program for distribution, but you'd want to leverage Medicaid dollars, matching federal funds, which is why we want it to be a Medicaid waiver, so we capture those funds. But if you wanted to do disbursement through WIC, we could do that. That would also allow us to do bulk buying. You'll see that Stratford County CAP is able to do bulk buying, and that reduces their cost for diapers in a huge way. I know that there is there's a nonprofit diaper producer that sells at cost because they're a nonprofit for this kind of purpose. So you could save money that way, but I wouldn't be able to speak to what the distribution in terms of staff to get it, to actually get those diapers, procure them, and get them out to places like WIC. So I think I don't want to speak for Representative Sorensen, but the idea is for it to be as low cost as possible while still meeting some of this need that's been Stratford County CAP has been able, and others have been able to meet, but it's going to end in September.
I actually have a question.
Yeah. Yes.
Yes. So fiscal impact, it says unable to complete a fiscal note because it's awaiting information. So now when would we expect that?
That's a question for HHS, but I think that and I don't want to speak for HHS, but I believe that the 900 for state funds might be based on children, this applying to children's Medicaid. And so I am expecting it to be lower than that if we did it on mother's Medicaid.
Okay, so I'm just going to follow up. It would be hard for me to vote on something that I don't know the fiscal impact of.
Oh,
so
for
okay.
sure.
Okay.
I appreciate
Thank
that.
you. Okay. Any other questions? Oh, Representative Weber.
I have one of the chair. Do you have an indication? I know that it's online, but the online system isn't working very well today. If this is an early bill, is this an early bill and therefore going to finance?
I believe there was only one bill today that wasn't an early bill.
Okay.
So, and I don't think this was.
Because that might give us a little more wiggle room if we could,
Yeah,
because
I don't think we have that on this one. So.
I also don't. Oh, I'm sorry.
Excuse me. I meant wiggle room on we could approve the policy, and if we know that the finance committee will be strictly reviewing the financial aspects of it as well.
Okay, thank you for that feedback. All right, thank you for your
so much.
testimony. All right, I'm seeing no further pink cards. Is there anyone? Yes. Do you have a pink card? Yes. Okay, thank you. You can bring that up. Appreciate it. Okay, Tia Middleton from the Manchester Diaper Pantry. Yeah, and if you could keep your testimony to 3 minutes. Thank you.
Good afternoon. My name is Tia Middleton. I'm a doula, mother of 4, and the owner and operator of a nonprofit organization called the Manchester Diaper Pantry. Today I'm here to enthusiastically support HB 1798 relative to the coverage of diapers under the state Medicaid plan. The Manchester Diaper Pantry is a small husband and wife run organization that operates primarily on in-kind donations and crowdfunding, with very minimal grant funding. The pantry was founded in 2019 by Gabby Teed and her husband, who recognized a consistent and unmet need for diapers in our community through their work at Amoskeag Health. My husband and I took leadership of the pantry in 2024. As a family living paycheck to paycheck ourselves, we intimately understand the financial strain that low-income families face, especially when it comes to diapering infants and toddlers. Once a month, with the help of dedicated volunteers, we distribute diapers to families in our community on a no-questions-asked basis. The families we serve are diverse. Some are temporarily between paychecks, others have lost a job, experienced a death in the family, or are navigating single parenthood. Many already receive public benefits such as WIC, SNAP, or TANF, yet none of these programs cover diapers, despite diapers being an essential non-negotiable need for every baby and toddler. On average, the Manchester Diaper Pantry serves approximately 100 families each month. Many of these families have more than one child in diapers. Diapers are not a luxury. They are a basic health necessity during the first years of life. The average family spends between $70 and $100 per month per child on diapers. For families already struggling to afford rent, food, and utilities, this cost alone can be overwhelming. Nationally, nearly 1 in 3 low-income families experience diaper needs, and what we see each month in Manchester reflects that reality. When families cannot afford an adequate supply of diapers, we see higher rates of diaper rash, urinary tract infections, and other preventable health complications that can lead to doctor visits or hospitalization. We also regularly encounter parents who are unable to send their child to daycare because they cannot provide the diapers, which directly impacts their ability to work and maintain stability. Families frequently tell us they are forced to choose between buying food for the week or buying diapers for their baby. In November of 2025 alone, our team distributed just under 6,000 diapers to low-income families in Manchester. Even with that level of distribution, it was not enough to provide a full month's supply for each child, and we were forced to close early and turn families away after running out of several sizes, a heartbreaking but very common occurrence. Last year, we participated in a pilot program through the Community Action Partnership of Stratford County that allowed us to provide families with a full month's supply of both diapers and wipes. Depending on the child's age, this ranged from 175 to 250 diapers per month. The impact was immediate and profound. During this pilot, we served a family living out of their car with a 2-year-old and newborn twins. Shortly after giving birth, the mother required extensive brain surgery, leaving the father of the children the sole caregiver and provider. Access to diapers through this program allowed the family to redirect limited financial resources towards securing temporary housing so the mother could safely recover. While diapers alone could not solve all of their challenges, removing that burden made a measurable difference in the stability of a medical crisis. One of our volunteers is also a single mother who works full-time. Shortly after the birth of her son, his father left and stopped participating in his life. While seeking assistance, she discovered our diaper pantry. She now receives diapers from us each month and volunteers her time to support other parents while facing circumstances, often bringing her son with her while she serves. Her story reflects what we see again and again. Parents want to work, to give back, and to care for their children, but they need the foundational support to do so. Diaper need is not simply a matter of convenience, it's a public health issue, an economic issue, a workforce issue. Covering diapers through Medicaid would directly support infant and toddler health, reduce preventable medical costs, and help parents maintain employment and child care arrangements.
If you could wrap up.
Yeah, of course. This policy will not replace community efforts like ours, but it would significantly strengthen the safety net for families that we are already serving so they can make ends meet. I urge you to consider this legislation as a practical, preventative, and compassionate step towards New Hampshire's children and the caregivers who raise them.
Thank you. Are there any questions? Seeing none, thank you for your testimony. All right, I don't see any more pink cards. Oh, do we? Or, is there one? I don't know.
Oh, I'm sorry, it's my fault.
Okay.
I'm very sorry.
Okay, we have.
I
one
just
more.
didn't look.
That's okay. All right, Steve Chapman from the New Hampshire American Academy of Pediatrics. If you, you indicated 2 minutes. That would be great.
I will aim for 2 minutes.
Thank you.
I'll aim for a minute and a half.
Oh, wonderful.
So I'm Steve Chapman. I'm a general pediatrician. I practice in Lebanon, grew up in New Hampshire, and I'm a past president of the New Hampshire chapter of the American Academy of Pediatrics, and I'm very much in support of this bill. In my clinic, we take donations when we can for all sorts of things, clothes, boots, and diapers when we can get them, and I can tell you how much that means to the families that I take care of. I've been through a lot of things in pediatrics, seen a lot of changes. One thing that hasn't changed is the need for diapers. I don't see that changing. And what it allows the families that I care for to do is to have something that they're going to need, that we know they're going to need, and give them a little bit of flexibility to do those other things to raise their kids well. I'm proud of New Hampshire for being the best state in the country to raise a kid, and it's steps like this that make it so. So I really urge you to support this. I see the value of it every day when I do have diapers to give to families, and I would love for them to have one less thing to worry about. Hope that was a minute and a half. Thank you.
Yeah, very good. Thank you. Any questions? All right, seeing none. Okay, we are going to close the hearing on HB 1798 FN. And actually, our next hearing is at 2, so we are going to take a break until 2 o'clock.
Back on track.
We caught up. Well done, everyone.
Okay, I'd like to reconvene. We'd like to reconvene the hearings for the Health, Human Services, and Elderly Affairs Committee. Next up is House Bill 1796 FN. And to introduce it, I'll recognize the prime sponsor, Representative Mike Moffett.
Thank you so much, Mr. Chair. For the record, I am State Representative Mike Moffett, Merrimack District 4, the wonderful towns of Canterbury and Loudoun. So I am an unlikely prime sponsor for a measure such as this, as I just mentioned to the Honorable former Representative from Hollis. I have always been very wary and skeptical of potential, or wary about potentials for substance abuse. And I've always been a hard no on marijuana for many reasons, to include the fact that I was constantly drug tested myself for many years in the Marine Corps, where I developed a zero tolerance for illegal drug use. So why am I, of all people, sitting here introducing a bill to make psilocybin legally accessible? So it also goes back to my military service. I do chair the Veterans Committee here, and I serve on several national legislative veterans or military task forces, several of them. And I was at such a task force meeting in Indianapolis last summer. And at that conference, we received a presentation. Our task force received a presentation on the efficacy of psilocybin's psychedelic qualities to treat PTSD, post-traumatic stress disorder. And there are, of course, countless veterans who have this condition, which certainly contributes to the high suicide rate afflicting our former service people. Here's a stat for you. In 2022, over 6,400 veterans took their own lives and committed suicide. Many, if not most, were PTSD related. 6,400, that's about as many people as we lost in 20 years in Iraq and Afghanistan in 1 year. Now, PTSD is not peculiar to the veteran population, as I'm sure you all know. Some of you, who hasn't had some horrific, stressful experiences? Well, many civilians certainly have as well. In 2024, here's another stat for you. Almost 50,000 Americans took their own lives. And so a psilocybin treatment option could have value to almost anyone beyond military people or former military people. Now, psilocybin's been debated on our House floor before, including just last year. And from that debate, I learned that psilocybin is a non-addictive psychedelic. That it is non-addictive is important to me, as I know the dangers in so many medicines and substances already out there that are addictive. So this is by far the largest bill I've ever introduced. I get it right here. It's 19 pages. Now, I didn't just sit down and type out 19 pages. Quite honestly, I looked to see what other states have done or tried to do or have in the mix. And Texas has spent a lot of time on this, Colorado, Oregon, of course, but also other states like Iowa. This language comes from an effort that has moved forward in Iowa. So, and we customize it. We took language that has already been scrubbed in other states, and we customize it, and here it is, customized for New Hampshire purposes. So, I've read and reread everything here in this, and I've marked up my own copy quite a bit. I think it's the first time I've ever testified in this committee, so I know you all probably are much more familiar with jargon, HHS jargon. You know the inner workings and hidden mechanisms of working through HHS. So you'll note that the language repeatedly calls for the department to utilize rulemaking powers granted to HHS to address details that need attention to implement any new statute. That's why we have rules. That's why we have JLCAR. So I will point to just one part of this on page 5. 1, 2, 3, 4, 5. Page 5, line 4. And that's the new proposed section 126-XX:7. So anyways, this line 4 on page 5, you'll see psilocybin licensing board. So that is really very, very key to this measure. If it moves forward, hopefully it moves forward in some fashion. Now you'll see that the psilocybin licensing board, there's a recommendation of 6, lines 8 through 16 describe a proposed 6-member makeup of this board. Again, this board would be key to the implementation of this new treatment option. So again, you can look at that as you discuss this or whatever. Obviously, it becomes your bill, and you can do whatever you're going to do with it. But the licensing board, obviously, I'm sure you already know this. You may think of other people or positions that should be part of such a licensing board. So there's that. There may be some privacy concerns. Again, I've gone through all this. I marked it up with my red pen, and there may be privacy concerns as I read the language, and some of you, if and when you get to scrub this, you may have some privacy concerns, of course, in terms of the licensing board, in terms of who's going to cultivate psilocybin, who's going to sell psilocybin, who's going to be licensed. It's not a simple measure, but the reason it is so long is because we try to be fairly prescriptive in anticipating all the different pieces of this that would need attention if or when a version of this can move forward. So, some related medical or clinical treatment aspects concerning HB 1796 might best be answered by medical professionals. I'm sure you will hear from some. You've had some people have submitted some written testimony, I know, online. There may be some that will testify in person. So I am not a doctor. I'm not a psychiatrist, obviously, but I am the person introducing this bill. So some of the treatment questions, I'd be happy to take any questions you have and try to answer them. But some of the treatment questions or the clinical medical questions would best be addressed by a doctor. And so that's my introduction. I'd be happy to, as I said, to try to answer any questions on anything from these many 19 pages.
Okay, thank you. Representative Weber.
Thank you, Mr. Chairman, and thank you very much for taking my question. From the depths of ignorance about psilocybin, but my knowledge of existing statute in New Hampshire, we do have a similar case with therapeutic cannabis, which is federally illegal and which has been authorized for use in the state under a sort of nod, nod, wink, wink. And I think that this is probably in the same situation. And my question is, would it be, instead of creating this whole new regulatory structure, would it be possible, or why would it not be possible, to simply add somebody with knowledge of this subject matter to the existing therapeutic cannabis structure, so we don't have to have two entire systems for the two different things?
Thank you for that. That's an excellent observation or thought. And of course, cannabis, psilocybin, apples, oranges, so to speak. But it's a very interesting point because cannabis is I know we have a lot of legalization bills regarding cannabis, which, as I said before, I've always opposed, ironically. But medicinal cannabis is legal, and I know HHS has structure in place to regulate and supervise the use of medicinal marijuana. So to perhaps take that existing structure with a lot of the aspects of which I think, why reinvent the wheel? Even though it is the apple and orange thing, but there's also many commonalities. So I think that's a very interesting and good point that hopefully the committee will follow up now that you have the bill.
Representative Drew, you had your hand up.
Thank you, Mr. Chair. As several states have discovered, when you build these giant bureaucratic constructs around attempting to make a drug legal, what you actually do is encourage the illegal use of drugs because it's simpler and cheaper and easier. California has discovered this, Maine has discovered this, a number of different states have. Is that a concern for you here? Because this is a very complicated, this establishes a bureaucratic structure. And
Sure. And there is no fiscal note. As you can see in the last page, OLS did make several requests of HHS for some fiscal note type information, which they haven't been able to supply yet. So I guess it's indeterminable. But I absolutely I get your point and your concern. Anytime that something is unregulated, if you go back to 1933 when alcohol was unregulated, that by necessity required our state liquor commission. So I guess the question for you all will be, once you get the numbers, is it affordable this term or in the future? And with regard to some of the cultural aspects about if you legalize something, well, this is not necessarily legalizing. If you read through this, the hoops people would have to jump through to access this psilocybin as a treatment are profound, and the structure and the guidelines, the guardrails surrounding this proposed are extensive. And now, of course, if people want to use a psychedelic now, obviously they do. It's illegal. Would this create pathways to use that wouldn't occur otherwise? One can only speculate. But the last thing I'll just say on that, I have two measures that I get from this military task force. One of them is this one, the psilocybin measure, and then there's another one coming later, ibogaine. And more so ibogaine than psilocybin, but I talked about this. Will it save lives? Well, I believe it would. How many people with PTSD could be treated out of that 6,400 that 1 year that we lost? It's an unanswerable question other than I believe that this treatment option would save lives. I can't quantify that. I can only say my belief and the belief of the supporters is this treatment option would save lives. And we passed a bill, Governor Ayotte signed it last year, on right to try. So whether it's ibogaine or psilocybin, if somebody is dying in this terminal, that was the purpose of the bill that we passed and the governor signed. And so rather than go to Mexico or whatever, if we can have some measure of sanction or legal imprimatur on this so that people who are dying can have this treatment option, then again, that's something I would support.
Other questions? Yes, Representative McLean.
Thank you, and thank you for taking my question. So, as I read the bill, and maybe you can clarify this for me, this is different than the licensure of marijuana or alcohol, in that this bill is setting it up as a kind of like an in-house treatment, right? So it's not like I have my marijuana card and I go down and I get my therapeutic cannabis, which I can take home to do. This is something that is administered in the clinic, right? So with the therapist, right. I thought there was videotaping of the session. Right. So this would not, it would be a completely different structure than what we're talking about with alcohol or the therapeutic cannabis. Am I reading the bill correctly?
Yes, there's the commonalities as we discussed earlier, and certainly differences. I mentioned the apples and orange thing, but the controls on this are profound. As I read through this and reread through this, it was so clear that the guardrails, as I put it, are so strong that it, by design, makes it almost impossible, but very, very difficult to abuse. So I don't see, unlike cannabis stores, I spend a lot of time in Oregon and in California, in Colorado. Cannabis stores are ubiquitous; they're everywhere, and in Massachusetts, they're everywhere. They're not in New Hampshire. So, were this to have some measure of legal sanction or whatever, you wouldn't see psilocybin stores around. You see the process is spelled out here. If this moves forward, there would be very controlled, very limited psilocybin access controlled by professionals through the licensing board that would give a few clinical people, clinicians, doctors, a treatment option that would be legal that's not legal now.
Representative Kesselring.
Thank you,
And
Mr. Chairman.
Representative
Thank you for taking my question. Do you know of any clinical trials that are being done on psilocybin?
Yeah, thank you. Question was about clinical trials already having been done on psilocybin. That's a great question. I know that this is from Iowa. I know Arizona has done a lot. I can't answer that. That's a great question, and I'll find out. Now I'm curious because that's something I should have looked up before I came here. But internationally, psilocybin, there are other countries where it is accessible, and other countries certainly have treatment clinical records on the efficacy of its treatment. As to what's done in the States, I'm not sure because it is mostly illegal. So I'm not sure how you do clinical trials with an illegal substance. But you folks in HHS maybe would know that better than me. But that's a great question.
Representative Hartnett.
Thank you, Chair McDonald. I appreciate you bringing this bill forward. I think it's an intervention that has a lot of potential. So two questions, really. One, if you gave any consideration before registering someone to be able to provide this treatment, that they would have to be mentored or somehow observe a current practitioner. Because at least to me, as a behavioral health provider, it seems a little thin on physician and clinician preparation.
Yeah, thank you for that. I know you said you had a two-part question, so let me just quickly try to address that a little bit. Now that you have the bill, you certainly could improve like the guardrail component in terms of what you're talking about. And again, this being your specialty in this committee, if you think the structures as presented are a little thin, as you put it, then you certainly could amend it to address that concern. Again, you can tell by the length of this that the sponsors and OLS and people in other states have really spent a lot of time trying to anticipate, all kinds of scenarios that they try to address here. But I'm sure that you folks who do this much more than I do can see, as I can tell you do, some places where it could be tighter or more secure. Yeah. And you got a second. Follow up, Mr.
Follow-up, sure. It's actually more just an observation. The same area where you define the training areas, you do a great job of saying, when is it indicated, when is it not indicated, what's the neurological stuff with receptors. But there's really nothing in here about what you actually do in a room with someone other than, I think, what's called integration. So what does someone do and say, the actual practice of? That could be beefed up as well.
Thank you for that. That is very interesting. I have never used psilocybin or a psychedelic that I've been aware of. So as to how it would be administered or applied, those are medical, clinical type questions I don't have answers to. But that's a great question because how in a clinical setting is it taken orally? Is it injected? That type of thing? Is it swallowed? Is it smoked? I don't really know how the medical professionals would, or if they have options in terms of how they would use psilocybin. the point here is not necessarily how they would do it, but to make it legal to do was my focus.
Well, you've certainly covered part one, the taking of the medicine, but then the mechanics of what happens after that could be.
Yeah, fascinating medical questions, and others besides me could answer it. Again, my focus was to give them the chance to use this legally as a treatment option that isn't there now.
Representative Mazur.
Yes, thank you for taking my question. So, do you know when we can expect a fiscal note on this?
Question was, do I know when a FN may be forthcoming? I do not. You can see that there have been, OLS has made 2 requests of HHS for FN information, and I'm sure they'll be reminded that we're waiting for, because that's incredibly important. How expensive is it? I know HHS does have some discretion over some. They can move some parts of their budget around, but I don't know when it'll be coming. But
there is someone from the department who signed up to speak and will be speaking.
Okay.
So they may be able to address it. I don't want to put them on the spot. But okay, anyone else? I don't see anyone. Okay, thank you.
Thank you all.
Also signed up to speak is Representative Henry Guyson, Goffstown, I believe.
Thank you, Mr. Chair. Representative Henry Guyson, Hillsborough 29th, Goffstown. I will be able to answer some of your questions here in just a minute, sir, because I've actually been on the phone with and doing interviews with some of the subject matter experts out of Iowa and Colorado for the past about 3 months now. One of the things that I would like to touch on is that there's multiple states and countries already doing this, and my veteran population down in the Fort Huachuca area, they routinely go over the border into Mexico for this treatment. Now that it's being legalized in Texas, that's not going to be as much of an issue. We are only just now coming to understand traumatic stress injuries. Really, it's kind of a fairly newly understood injury, certainly in the past 50 years, maybe even in the past 20, that we've started to wrap our head around it. And up until this point, many treatments rely on psychotropic medications, which also come with a side effect. I'm sure you've all seen the commercial on TV, take this antidepressant, but you might want to kill yourself. That's not really a good way to wrap your head around this when this isn't a traditional depression or anxiety. This is a traumatically driven event. And there's a lot of focus on the veteran community. I don't know if it would surprise the chair to know that combat stress doesn't even make the top 5 of top stressors in the United States. Which start off as injury accidents, car accidents, child domestic abuse, sexual assault, physical assault, and criminal threatening. Those are the top 5 reasons to have a traumatic stress injury in the United States. Combat's about number 6. So in coming to understand this, there's a lot of new treatments that are coming up on the grid. Recently, they brought on board stellate ganglion block. If somebody's not familiar with it, that is the use of I just forgot the word, anesthesia therapy to numb the nerve band that goes to the medulla to control fight or flight instinct. I actually took that treatment about 1.5 years ago, and it was life-changing for me. If that treatment had not worked, my options would be try to find something like this, or go back to the psychotropic pharmaceuticals with their high risk rate. We need to be exploring healthcare options for this really new to our understanding illness, so to speak. Now, as for your question as to how it would be implemented in a pharmacy or in the presence of a doctor, my understanding is that it's treated a whole lot like EMDR, which I'm sure you're familiar with, where they try to relive certain conditions while you are in the therapeutic state, and in this case with the assistance of the medications, in order to desensitize the reaction process or the panic instinct from that traumatic experience. So in that regard, it plays a lot like EMDR. I think that covers everything that yes, pending any questions, Mr. Chair.
Okay. Any questions? Representative Drew.
Thank you, Mr. Chair. You stated that many veterans in Arizona are crossing the border to go to Mexico to get this treatment. If Arizona or nearby states had implemented a regime like this, which is bureaucratic and relatively cumbersome, do you think that they would still go to Mexico simply because it's easier?
I don't necessarily think so. It also is going to depend probably on how it plays with the insurance or whether it's completely elective procedure. When you, for lack of better, when you cross the border to get care in another country, you're absolutely paying out of pocket. Most U.S. insurance won't cover that unless it's a specific injury referral or long-term illness referral. So we're talking about a treatment that, while some may consider it elective, many of us believe it is life-saving. And if there was an option that, it come up on and become normalized and even be covered by insurance, then I don't think they would be crossing the border unless they're just comfortable with that particular doctor. I can tell you with my stellate ganglion block procedure, I was prepared to spend about $8,000 to go have it done in Maryland, because they were one of the first states that brought that up on grid and legalized it, and it would have been completely out of pocket. The VA and the state of New Hampshire only brought that up on grid 2 years ago, and I was, I think, the 5th patient to get it in the Manchester VA. So I hope that answers your question. Thank you.
Anyone else? Okay, I guess we're all set. Thank you. Also signed up to speak is Jenny O'Higgins from the Department of Health and Human Services.
Good afternoon, Chair and members of the committee. For the record, my name is Jenny O'Higgins. I am the Legislative Liaison for Behavioral Health at the Department of Health and Human Services. The department is not here to take a position on HB 1796, but does want to provide you information around this proposed legislation. So as you know, the legislation that is proposed is establishing some regulated medical psilocybin program that would be under DHHS oversight, and creates a licensing framework for the therapy providers, cultivators, and testing labs, clinical setting administration, and annual reporting. So as we have already heard today, the fiscal note has not yet been attached to the bill for your review. It was submitted by the department to the LBA on December 30th, so we imagine that will be forthcoming very shortly. We do have some concerns around the no direct appropriation provided in the bill for any startup, and as you are all very aware, with DHHS current budget, we would not be able to absorb the startup or ongoing costs with our current operating budget. And we would expect a significant increase to state expenditures as a result of this proposed legislation and indeterminable revenues. The fiscal note range was from 1.25 million to 4 million at the upper end. The fiscal note, I'm so sorry that you don't have it right in front of you to be able to review, but it does include, the stand-up of the regulatory board and licensing registration systems, the infrastructure of an IT system that would be needed that is in the range of 1 to 1.25 million. And then the implementation of the training and continuing education pieces and multiple positions that would be required for program oversight and administration. I know you've also talked a bit about the therapeutic cannabis program sitting in public health, and the fiscal note we were able to utilize that program in order to make some estimates about how we would run this. So the department would be responsible for developing and implementing the entire medical psilocybin program under this proposed legislation. So there is some significant pieces of work that we do not do today and do not currently have expertise in. And so you'll see the details of that in the fiscal note, but I'd be happy to take any questions if I can be helpful.
Thank you. Questions? Representative Weber.
Thank you, Mr. Chairman. Thank you for taking my question. My question is the same one I asked Representative Moffett, and you've partially answered it because you've said you used the therapeutic cannabis program as a model for how this might be implemented in your determination of costs. Does that imply that it would be yet another completely freestanding program, or are there ways, or are there not ways, despite the fact that they're very different processes, is there any way that some of the existing structure could be used, given that both of these are a way of dealing with the fact that things are federally illegal, and much as I think a lot of us would like many of these things not to be federally illegal, but simply allowed for the appropriate practitioners to be able to prescribe them along with all the other things that are potentially very helpful and also potentially very risky. Can we avoid duplicating the entire infrastructure, or is that really not possible because of the difference in the substances?
I think when we look at this, we're looking at their differing treatment protocols, as you've talked about, and differing expertise that the department does not currently have in this area. So while there may be a like type program, it would take still the significant staff for the oversight. So the fiscal note is based on the additional staff that would be needed, even if there were ability to utilize some existing staff in the therapeutic cannabis program. We still would need additional positions for the level of oversight and the amount of responsibility, in developing the program at the department. So you'll see in the fiscal note sort of which positions we're thinking would be required, as well as the IT infrastructure and things. And that would be in addition to therapeutic cannabis program, even if we could find some similarities and potentially have a shared position in different areas.
Thank you, very helpful.
Anyone else? Okay, guess we're all set. Thank you.
Thank you.
Also signed up to speak is Sue Homela from Sam, New Hampshire.
Hi, I'm Sue Hamola from Hollis, New Hampshire, and also representing Smart Approaches to Marijuana in New Hampshire. I wanted to start off by saying I have great empathy, and I appreciate Rep. Moffitt's his empathy for veterans, for folks with PTSD, for those suffering. I'm actually an Air Force veteran, active duty 7 years. My husband's been on active duty for 24 years and is retired. I have 3 of my 4 children are in the military. My daughter and my son-in-law are both Air Force pilots. My son graduated Navy flight training yesterday, and my other son's a Marine infantry lieutenant. So the potential for any of my children getting PTSD while they're on active duty is near and dear to my heart. So I appreciate the interest in trying to find emerging solutions for that. I really do. I will say, though, psilocybin is a Schedule I federally legal drug. No matter what we discuss today, that doesn't change that fact. The medicinal uses for psilocybin are not yet proven, and according to the American Academy of Psychiatry, quote, there is currently inadequate scientific evidence for endorsing the use of psychedelics to treat any psychiatric disorder except within the context of approved investigational studies. Clinical treatment should be determined by scientific evidence in accordance with applicable regulatory standards and not by ballot initiatives or popular opinion. They also go on to say, with the excitement and development around psilocybin's therapeutical potential, there is a risk for increased bias concerning its potential effects by those administering the treatment. The one thing that I will tell you, the one thing that really concerns me is who's pushing. I always like to go, who's pushing this? So this effort is actually being pushed by the Psychedelic Science Funders Collaborative. And who are they? They're actually a small handful of high-value Silicon Valley people. According to one of the collaborative's members, quote, this field has been carried by like 20 families, and the leverage that they've had with $1 million, tens of millions of dollars, hundreds of millions at this point, is really quite extraordinary. One of the things that I found particularly offensive, to be honest with you, is one of the co-founders of this Funders Collaborative is Joe Green, and he's actually said that they are pushing for psychedelics for veterans treatments, for using veterans under veteran care, because vets are, quote, the most sympathetic group in our country. So that is particularly concerning for me, and it's been noted by other people. There's a group, all the information, by the way, that I have today is already been emailed to you with links that you can check my work. I always cite references. But there's a group called Symposia, and they actually did a 4-part series called How Silicon Valley Used Veterans to Hijack the Psychedelic Industry. Now, this doesn't disparage any veteran who's actually trying in good faith to get treatment and deal with the consequences of PTSD. Sorry. Deal with the consequences of PTSD, but it is a fact that this is actually getting pushed by some high dollar individuals, and they follow the same playbook. To be honest with you, what they end up doing is they end up overstating the benefits, underemphasizing the risks, and then pushing for capturing the regulatory process, starting at the state level, using a sympathetic group to push it. The one thing that is in there, there's a big backstory on experimenting with the military with psychedelics. The Citizens Commission on Human Rights has a very detailed investigation on how military members and vets are constantly being exploited by the pharmaceutical industry. One of the things that we see here is from one of their investigative reports from 2001 to 2009, the Army suicide rate increased more than 150%, while orders for psychiatric drugs rose 76% over the same period. And they're saying these soaring statistics cannot be only attributed to people in combat, since 85% of military suicide victims have never seen combat. And this is suggesting that PTSD diagnoses themselves are being widely handed out to active duty vets, and quite frankly, just to justify putting them on more psychedelic or psychiatric drugs. I mean, anyone who's ever been in the military, if you go on deployment and you line up in the vaccine line, tell me that you don't feel like a guinea pig. So I have a 2-part concern. My 2-part concern is, one, the military community cannot be experimented on anymore. If we want to do this, let's do it at the federal level. Let's let these Silicon Valley bros put all their time and effort to go and talking and advocating and working with the FDA and working with the DEA and working with the American Psychiatric Association, who is very open to new things. They welcome research in this field. We don't push it at the state level so we can experiment on more vets. And I will say, just as a note, the only 2 places right now that have these treatment centers, Colorado and Oregon. In Oregon, interestingly, actually in Colorado, the number of psilocybin calls to the poison control increased over 317% just in the last few years. And as far as Oregon goes, the Oregon Psychiatric Association and the American Psychiatric Association have both highlighted, quote, the lack of phase 3 clinical trials of psilocybin and the potential dangers of allowing non-physician providers to administer an experimental drug to patients with medical and psychiatric disorders. So the other examples of legislation, in California, there was a bill to create a pilot program like this, but it was actually vetoed by Governor Newsom. And then in Iowa, they had a recent bill to legalize psilocybin clinics for PTSD folks, and it was withdrawn, as best as I can tell on my research. So my takeaways to this is that psilocybin needs to be studied in a more rigorous manner before we start rolling out and experimenting on vets. And I do empathize with those who suffer from PTSD greatly. Does anyone have any questions for me? Yes, sir.
Do you have a resolution for the problem that once a drug is assigned to Schedule 1, it becomes nearly impossible to actually get the medical evidence that you need, the clinical evidence that you need in order to introduce it as a treatment? How do you solve that problem?
So, you know, funny you say that, because as pot has been a Schedule 1, right? So as far back as the 1970s, the United States Department of Justice actually gave Philip Morris the ability to study marijuana and its ill effects or any effects in it. I'm pretty sure that if the DOJ of the 1970s can give Philip Morris marijuana so they can study the health effects of it, that they can probably figure it out in 2026. So.
Other questions? Seeing none? Okay, thank you.
Thank you, sir.
No one else has signed up to testify on HB 1796 FN. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on this bill. The next one is noticed for 3 p.m., which will be 1809 FN. So we'll be in recess for the next 17 minutes or so. Good afternoon, everyone, and welcome back. Last bill of the day, HB 1809FN, and I'll recognize the prime sponsor, Representative Scher, to introduce the bill.
Thank
Good
you,
afternoon.
Mr. Chair. I envy you here on this committee. We are 2 hours behind in criminal justice, which is next door, and we have a red flag bill and 3 death penalty bills to go.
We were behind quite a bit earlier, but
Yeah, we're not catching up. We're going to leave at half past midnight, I think. I'm sorry. My name is Representative Buzz Scher. I represent Rockingham, District 26. I am, which is Portsmouth Ward 3. Just to be clear, I'm also a incoming chair of the Portsmouth Police Commission, which I was recently reelected to another 4-year term. I'm not speaking on behalf of the Police Commission. And I'm also semi-retired, working part-time at UNH Law, where I had worked previously for 32 years. And I'm not speaking on behalf of the University of New Hampshire or University of New Hampshire School of Law. I'm speaking in my capacity as a representative. I know you've heard one psilocybin bill already. I offer this bill as an alternative. It is what I would call psilocybin light. It is the main focus of the bill is an advisory council. I think to talk about that, there's a substantial amount of research going on currently about the therapeutic uses of psilocybin. The research in terms of it helping with those who have treatment-resistant depression is pretty significant at this point. Research in terms of a broader use for those suffering from other forms of PTSD, post-traumatic stress disorder, is developing. Research for use with people who have certain forms of substance abuse is also developing. The point of having built into this bill an advisory committee or council, I forgot what I called it, is to have people knowledgeable in the field talk about this and think about this and look around at what's going on around the country. Oregon has a therapeutic psilocybin structure. Colorado has one that's just gone into effect recently. Those are very substantial bills. In Oregon, it was related to the legalization of psilocybin, so it's a very different form. Colorado is much more regulatory heavy by design. It's a very substantial organization. They've made that financial commitment in terms of regulation. I attended last fall a policy summit at Harvard Law School that gathered together all the people, all the regulators, all the scholars, all the scientists doing work in therapeutic use of psilocybin. And we spent a day having a very, very good conversation about it. And I had the good fortune to sit next to the chief administrator of the Colorado program. And I said to him, because I had already drafted this bill, I said to him, so if this bill were to pass with the advisory council, would you be willing to serve on it? And he said that he would. I specifically built into the advisory council piece of this that meetings can be held through Zoom electronically. So we wouldn't be paying for him to come from Colorado or whoever, is in Oregon if we wanted somebody from Oregon, or one of the scientists who I talked with from Johns Hopkins, who's the leading scientific researcher in this area. They could all participate in the advisory council, and it's set up for a 2-year advisory council. The substantive piece of this in terms of the program is what I would call regulatory light. I think, though I believe I was a co-sponsor of Representative Moffitt's bill, I intentionally designed this after very, very helpful conversations with people at HHS. And this is my bill, it's not their bill. I intentionally designed this as being regulatory light. There's not testing. It creates a circumstance where the provider of the provider of the therapeutic psilocybin services has to be the producer of the psilocybin. It is not illegal to produce having your possession psilocybin spores. So the provider would grow their own psilocybin, and they would need to be approved under the bill as I've written it. But that is the extent them getting approved and HHS documenting the number of those who are producer providers is, relatively speaking, the extent of the program. So it's much more regulatory light. I keep talking with people about this, and I was so much better informed than when I started out, having talked to HHS and having been to this symposium, this policy summit down in Cambridge. And I am more than willing to entertain an amendment to this and to write one for the committee and whoever is willing to offer it, that would reduce this to just an advisory council. I think it's really important that we do this carefully and we do it well. And the advisory council is the most important piece of this bill. I would, in retrospect, I would make some changes in who would be on the advisory council based on my experience at the policy summit, and I'm more than willing to write an amendment that would make the changes in the advisory committee composition and eliminate the limited program that I put in there and just have this be an advisory council. So I think that's all I have to say. More than willing to entertain questions.
Okay, thank you. Any questions? Representative Lamontagne.
Thank you, Mr. Chair, and thank you for taking my question. I'm curious about why you just decided that the provider, the therapist, must also produce their own product. It seems that you may have very good therapists that are not at all interested in growing these mushrooms or producing a product, and they would maybe prefer to buy use a product that's standardized and tested elsewhere, so they know exactly what dosage they're giving.
I agree with you. But once you have an independent producer of the psilocybin, you run into a host of regulatory issues that DHS would have to deal with. It almost instantly becomes a bigger regulatory issue, and I wanted to, at the front end, before we understand as much as we want to, I wanted to avoid that. That was the point. The problem here is the difference between this and medical marijuana is that bill, that program, such as it is designed to pay for itself. And it has 12,000, 17,000, I forgot what the number is, perhaps others can say. That's possible under that kind of bill, but you're not going to get those kind of numbers with therapeutic psilocybin. This is not a regulatory process, given the number of people you're going to license as providers or producers, that there's not going to be enough people that are going to pay for what it costs DHHS to administer the full regulatory thing. So I would prefer in the long run that be the model, that good therapists could get the psilocybin from producers, but it's just not practical in terms of regulatory structure in this time when we don't have that much money. So yes, I'd like that, but not time for it yet.
Other questions? Representative Kesselring.
Thank you, Mr. Chairman. Thank you for taking my question. So looking at the fiscal note, it looks like the advisory council might be the biggest part of the expense is what they're saying to oversee.
Yes, and that's a very limited staffing expense, very limited staffing expense if it's just the advisory council. I think you're going to hear others from DHHS testify more about the fiscal note.
Anyone else? Seeing no one? Okay, thank you. Also signed up to speak is Jenny O'Higgins from the Department of Health and Human Services.
Good afternoon, Chair and members of the committee. For the record, I'm Jenny O'Higgins, Legislative Liaison for Behavioral Health at DHHS. So again, the department is not taking a position on this bill, but are here to provide information. So as you just heard from the prime sponsor, the bill is significantly different than the bill that you heard earlier today in that it creates, with the department, more of a registry program for providers who would also be producers. So the proposed legislation would require the department to create and manage that registration and take in the applications for those who would be able to use medical use of psilocybin in that program. And the department would approve the medical providers and then host the registry for people to be able to find those providers. So there is a significantly different fiscal impact in this bill than in the previous bill that we heard today, in that the department sees no impact on state revenues and then state expenditures potential to increase. The first year of the program, when at passage of the act, the department would need one staff position. And additionally, in the following years, as a board certification of the program readiness, if the board certified that the program is ready to start up, we need an additional staff position for that oversight. And then there are some indeterminable costs of the oversight of the program generally that we don't have a handle on because we don't really have an exact program. One of the major things that did bring down the costs is the lack of a need for the IT infrastructure that we talked about in that previous bill as well. So that gives you some sense of sort of the differences in the two bills that we heard today and the needs of the department to be able to oversee those. And I'm happy to take any questions.
Thank you. Anyone have any questions? I'm seeing no questions. Oh, Representative Lamontagne.
Right. I guess I'm following up on Representative Weber's questions earlier regarding the other bill, as to whether you thought that it could be incorporated into the therapeutic cannabis program, and perhaps the director of that program might also testify.
Yes, so Mike Holt can join me at the table as the director of the therapeutic cannabis program. The department would likely need a position to add to that program.
Thank you. For the record, my name is Michael Holt. I'm the administrator of the Therapeutic Cannabis Program with the Department of Health and Human Services. As my colleague has said, this bill is very different. It's regulatory light. The sponsor has said this as well. If we look at the effective dates of this bill, what we see is the board or the council gets approved first. They do their work for as long as it takes for them to do their work. If they give the program a go-ahead, then the rest of the bill takes effect. So if the department were to be responsible for facilitating the work of that board for the first 6 months, year, 2 years, or however long it took, if your question is it possible to absorb that cost? If the bill passes, we can answer that question better, right? It would be better to have additional staff dedicated to that purpose of facilitating the board, assisting with research, and doing that kind of work. I hesitate to say yes. We can't absorb any more work in this economic climate, this fiscal climate.
Do you have a follow-up?
Oh, that's okay. Just from your experience running the therapeutic cannabis program, do you think producers of therapeutic cannabis could be dual licensed to produce psilocybin products?
We would need to ask the question if they were interested in the endeavor. We would need to ask the question of explore the differences in what it takes to cultivate mushrooms versus a plant product. I'm not sure that the expertise is the cultivation needs are the same. Is it possible they want to? It's possible. Is it possible they can do it? It's possible, but without really exploring the bed of expertise needed, I can't say it for certain. I know that a year or two ago, Representative Verville proposed legislation that would have allowed the ATCs, the alternative treatment centers that do produce the therapeutic cannabis, and place the responsibility on them to grow mushrooms, synthesize LSD, DMT, etc. I'm not sure how far that bill went. We got in the process.
Anyone else? Yes, Representative Woods.
Thank you, Mr. Chair. Continuing along with that last question, do we really have anybody in your area? Sounds like not, but is anybody that can tell us what is involved in cultivating the process of cultivation and maintaining to the same degree of oversight which you have with cannabis in terms of the different species, et cetera, to make sure that the product is indeed what it should be?
Well, I think that's why we have the positions in both of these bills, is really that the current department infrastructure doesn't have the expertise in this area. So we'd be looking to hire to make sure that oversight would be we would be up to that level of expertise to take on a new and different program.
So the answer to my question is no. We don't have any insight. So that question we don't have, or the answer we don't have yet.
And we haven't looked into the question either because it's not the bill. And,
yeah, correct.
Right. So
it would impact us in terms of.
Yes.
I would just piggyback and offer that the point, I believe, of the advisory council would be to develop that knowledge base and serve as a resource to answer those kinds of questions.
Anyone else? Seeing no one else? Okay. Thank you. Also signed up to speak is Sue Pomola from SAM of New Hampshire.
Thank you. I'm Sue Homola from Smart Approaches to Marijuana, New Hampshire. I appreciate Rep. Scheer's desire to do this in a very controlled, cautious manner. I will say that if the bill gets amended and it turns into an advisory council, and the goal of this advisory council is still to authorize a federally illegal Schedule I drug for state level use, then SAM New Hampshire will still oppose that effort, because overall what we're still talking about is, again, we're still talking about a Schedule I drug and trying to do something with it that we're not doing at the federal level. That with it also brings the same sort of FinCEN financial problems that you have with whatever kind of profits get generated from any of these, whether it's through DHHS or whether it's through any kind of clinics or anything like that. That's a whole other banking problem that still hasn't been resolved. I will say that one of the things that we're not really discussing too much, all of this, and it quickly gets lost, and it goes down to that, what I was saying about the Silicon Valley push for psychedelics is you overstate the benefits and you underemphasize the risks. We're not talking at all about are the studies that are getting done right now, are they legitimate? There's a lot of unscientific and unauthorized studies being done right now, and there's one group called MAPS. If you look them up, their goal is to make Molly legal. Just why not? But I believe that one of their studies just got pulled from the federal government. I mean, it was just kind of crazy. But these studies are not getting done under controlled settings. Like I said before, the American Academy of Psychiatrics, they're interested in this. You know, they want to study this, but we have to have it studied in the right way. There's a University of Wisconsin doing a retrospective. They found that 1 in 20 people report ongoing adverse effects after using psilocybin. 2025 Canadian Medical Journal reported a link between bad trips and a 2x increase in death, and suicide was the actual most common cause of death. In the U.S., one of the things that we have to discuss is ever since the push for psilocybin has come on the scene, we've had a lot, the DOJ has highlighted how this is becoming a drug of abuse of young people, because when you legalize a federally legal drug for any purpose, it actually gives young people the impression that there aren't risks. And that's actually that's just a dangerous road to go. So one of the things that I think that we have to kind of look here again is kind of looking back and looking at who's pushing it, why are they pushing it, who gets to benefit. And I just think if your model is based off of a state, if the model is based off of a state legalizing a federally legal drug, then you've already started with the rocky foundation. So thank you very much.
Thank you. Any questions? Seeing no questions? Okay, thank you very much. No one else has signed up to testify on HB 1809 FN. Does anyone else wish to testify? Okay, that concludes our work for today then. That was our last hearing. We have a full day of hearings scheduled for next Wednesday, January 21st. And with that, we will adjourn for the day.